Welcome to the Deep Dive, where we cut through the noise, dig into the latest research, and really hand you the essential insights you need to get smart on complex topics. Today, we're diving deep into an unsung hero of your body, a part you likely never think about. Well, until it decides to complain. The esophagus. Looks like a simple tube.
Yeah, at first glance.
But what our source reveals is it's actually a complex and relatively durable organ performing this incredibly intricate dance every time you swallow, and it traverses some truly precious territory from your neck down to your stomach.
It's true. I mean, we swallow countless times a day without any effort or pain or even a second thought. This precision of a normal esophagus is virtually unrecognized. Yet, when disease strikes, it can lead to conditions that are, well, quite severe and invariably chronic.
And that's exactly our mission for this deep dive. We're going to unpack its intricate anatomy, its physiology, explore the wide array of maladies it can face, and delve into the cutting-edge diagnostic and therapeutic advancements. That includes the really complex world of esophageal cancer management.
Right.
Our understanding today comes from a highly authoritative source, a professional medical textbook on surgery. So think of this as your shortcut to becoming truly well-informed on this specialized topic. You'll gain insights akin to an elite professional in the field.
And while it's true we haven't found, perfect solutions or true renewal for many esophageal dysfunctions, it's really vital to highlight that advances in perioperative care, surgical safety, and minimally invasive as well as endoscopic techniques have improved patient outcomes.
Okay.
So we're going to guide you through this complex landscape, and hopefully you'll finish with a really profound appreciation for this incredible organ and the innovations it continues to inspire.
Excellent. Let's dig in.
Let's do it.
So let's start with the elegant blueprint, the anatomy of the esophagus itself. Our source describes it as a two-layered, mucosa-lined muscular tube. It's about, 25 to 30 centimeters long, starting high up at the base of your pharynx around the C6 vertebra and ending down in your abdomen at the cardia of the stomach near T11.
Exactly. And what's really fascinating about its path, is how it winds its way through a path yielding to structures of more vital efforts. It's not just a straight shot down.
Right.
It starts in the midline of your neck, then shifts slightly left of the trachea, then down at the carina where your windpipe branches, it actually veers right to make room for the aortic arch. Then it winds back left, ducking under the left mainstem bronchus, before finally entering the diaphragm through an opening called the esophageal hiatus right around T11.
So it's like a carefully planned route.
It is, and it's secured, by your spine in the back and then by your trachea, heart, and pericardium in the front. Just before it hits the abdomen, it's actually pushed forward by the descending thoracic aorta, separated by the structure called the median arcuate ligament.
It's really navigating a crowded and vital neighborhood then. And it has these two distinct high-pressure zones, the upper and lower esophageal sphincters, the UES and LES acting like gates.
Yeah, gates at the beginning and end. And beyond that upper gate, the UES, it's sort of segmented into 4 parts: pharyngeal, cervical, thoracic, and abdominal.
Okay. Tell us more about the UES, that upper gate.
Right, the UES. It's that critical high-pressure zone right at the entrance, and it marks the end of a really complex muscular configuration coming down from your larynx and pharynx. Now, you have 3 pharyngeal constrictor muscles, superior, middle, inferior. They anchor the pharynx and larynx, helping with swallowing and speech, but they aren't the main source of the UES pressure.
So which muscle is?
It's the inferior pharyngeal constrictor that's key here. It's made of 2 muscle beds: the thyropharyngeus with its oblique fibers, and the cricopharyngeus with horizontal fibers. And it's that distinctive bowing array of the cricopharyngeus muscle that actually creates the UES high-pressure zone and the esophageal introitus, the very opening.
And this area has a point of vulnerability, doesn't it? I think I read about that.
You did, yes. Between the thyropharyngeus and cricopharyngeus lies a potential weakness known as Killian triangle.
Killian triangle.
Yeah, and this is the classic spot where a Zenker diverticulum can form basically an outcouching of the esophageal wall. There's also another spot, the V-shaped area of Lamer, flanked by longitudinal esophageal muscles. So even at the very start, there's this delicate balance, precision, but potential weakness too.
Speaking of distinct features, the layers of the esophagus itself are quite unique compared to the rest of the digestive tract. Our source points out it has 2 proper layers, the mucosa and the muscularis propria, but it's distinguished by its lack of a serosa. Instead, it's wrapped by adventitia. Why is that lack of serosa significant?
That's a critical difference, yeah. Most other parts of your gut, like your intestines, have this slippery protective outer layer called a serosa. It helps them slide against other organs, provides a bit of a barrier.
Right.
The esophagus doesn't have that. It's surrounded by adventitia instead, which is more like a fibrous, less contained layer. This makes it, well, more vulnerable, especially if there's a perforation. Because there's less inherent containment, less natural sealing, infection can spread much more rapidly into the surrounding chest cavity or neck.
Okay, that makes sense. So let's break down those layers, starting from the inside out. The innermost layer is the mucosa, mostly squamous epithelium, kind of like the skin lining your mouth and throat.
Exactly. But near the stomach, just the last 1 to 2 centimeters, it transitions to a different type of lining, cardiac or junctional columnar epithelium. That transition point is called the Z-line.
The Z-line.
And the mucosa itself has 4 distinct sublayers: the epithelium, the basement membrane, the lamina propria, and the muscularis mucosae.
And deep to that.
Deep to the muscularis mucosae is the submucosa. This isn't just filler tissue, it's a really rich network of lymphatic vessels, blood vessels, mucus glands to help lubricate things, and the Meissner neural plexus, a nerve network.
And that network is important.
Crucial, both for normal function, but also, unfortunately, for how quickly diseases, especially cancers, can spread through those lymphatic and blood vessels.
Right. And then enveloping all of that is the muscularis propria. That's the muscle layer doing the pushing.
That's the one. It's got inner circular and outer longitudinal muscle bundles, but it also has this really interesting transition in muscle type.
Oh.
The upper third is striated muscle, like the muscles you consciously control in your arms or legs, but the lower 2/3 are smooth muscle, like the involuntary muscles that control your intestines.
Huh. Why are they different?
It likely relates to the initiation of the swallow being more voluntary or rapid up top, transitioning to the slower involuntary wave-like contractions, peristalsis, further down. That transition is key to understanding its function. Those circular muscles even extend a bit into the stomach, forming the middle circular muscles of the lesser curvature. And there's a specific landmark surgeons look for, the collar of Helvetius, or loop of Willis, marking that precise transition to the stomach's oblique muscles. And nestled between these muscle layers, we find another nerve network, the Auerbach plexus. This, along with the Meissner plexus in the submucosa, forms an intrinsic autonomic nervous system. Basically, the esophagus's own little brain, vital for coordinating peristalsis.
Fascinating. And the outer longitudinal muscles.
They originate way up near the cricoid cartilage in the neck and extend all the way down into the abdomen, joining the longitudinal muscles of the stomach's cardia. And finally, wrapping the whole thing is that outer fibroalveolar adventitia we mentioned earlier, the layer instead of a serosa.
So clearly not just a simple tube. It's a finely tuned muscular machine with its own complex nervous system. And it's not uniformly wide either. The source uses an hourglass analogy for its shape, describing 3 distinct areas where it narrows.
Yeah, these constrictions, or narrowings, are clinically very important. The narrowest point of the entire gastrointestinal tract is actually right at the top, at the cricopharyngeus muscle. It measures just 14 millimeter across.
Oh, the narrowest. That's where things would get stuck.
Absolutely. Foreign bodies often lodge there. Then, a bit further down, just below the carina where the trachea splits, you have the bronchoaortic constriction. This is caused by the left mainstem bronchus and the aorta pressing against the esophagus. That measures about 15 to 17 millimeter.
Oh, okay.
And finally, there's the diaphragmatic constriction, where it passes through the diaphragm muscle into the abdomen. That's about 16 to 19 millimeter. Between these narrow points, the esophagus expands back to its normal adult diameter, which is roughly 2.5 centimeters.
And then we finally reach the gastro-esophageal junction, the GEJ, that critical transition into the stomach. You mentioned the UES and LES act as gates, but the LES is anatomically much more complex. How do doctors identify this vital junction?
Good question. Endoscopically, when they look inside with the scope, there are 2 main identifiers. First, that squamo-columnar epithelial junction we mentioned, the Z-line, where the pinkish squamous lining meets the redder columnar lining of the stomach.
But you said Barrett's can change that.
Exactly, that's a caveat. In a Barrett esophagus, that line can move upwards, so it's not always a perfect landmark on its own. The second endoscopic point is where the smooth esophageal lining transitions into the rugul, folds those characteristic internal wrinkles of the stomach. That's usually a very reliable marker for the GEJ.
And externally during surgery.
Externally, surgeons look for that collar of Helvetius, where the esophageal and stomach muscle fibers blend, and also for the gastro-esophageal fat pad, a little collection of fat right at that junction. These consistent anatomical markers help define this complex area.
That's a lot of precision packed into one small area. Okay, finally, for anatomy, let's talk about the highways and channels serving this organ. Its vasculature, lymphatics, and innervation. The source emphasizes the rich vascular and lymphatic structures as both a surgical safety net and a highway for metastases. That image is, well, both comforting and a little alarming.
It is, isn't it? The arterial supply, the blood coming in, is segmented, much like the esophagus itself. The cervical part gets blood mainly from the inferior thyroid arteries. The thoracic part receives direct branches from the aorta and bronchial arteries, plus some help from intercostal and phrenic arteries.
And the abdominal part.
Down in the abdomen, it's mainly the left gastric artery and the paired inferior phrenic arteries. And all these arteries ultimately branch into a really fine capillary network that penetrates the muscle wall and continues into that submucosal layer, ensuring a robust blood supply all the way along.
So it's very well perfused. And the venous drainage, the blood going out you mentioned, is just as complex.
Absolutely. It largely mirrors the arterial supply. There's a rich submucosal venous plexus, a network of veins just under the lining that acts as the primary collecting basin. In the neck, this blood drains into the inferior thyroid veins. In the chest, it joins superficial esophageal veins and others, draining into the azygos and hemiazygos systems. In the abdomen, it's interesting because it drains into both the systemic circulation via phrenic veins and the portal venous system, the system going to the liver via the left gastric or coronary vein and short gastric veins.
Why is that dual drainage important?
Well, clinically, it explains things like esophageal varices in liver disease, where portal hypertension backs blood up into these veins. But generally, this extensive vascularity means the esophagus is remarkably durable for surgical manipulation. You can mobilize it quite a bit without losing its blood supply. But as you noted, it also provides a clear, efficient pathway for spread, like cancer metastasis.
Which leads us neatly to the lymphatics, another extensive network. These are like a secondary drainage system, right?
Yes, consisting of two interconnecting plexuses, one in the submucosa and one in the muscularis, draining into regional lymph nodes. Think of the lymphatics as a superhighway for disease spread, especially cancer.
Why is it such an oncologic challenge?
Because this network is so extensive and interconnected, especially across 3 body cavities, the neck, chest, and abdomen, even a small tumor can potentially spread incredibly quickly and widely. The flow patterns are generally upward in the upper 2/3 and downward in the distal third, draining to nodes like the paratracheal, deep cervical, internal jugular in the neck, and various mediastinal nodes and the thoracic duct in the chest. It's an intricate web.
It really is a stark contrast. Durable enough for complex surgery, but so vulnerable to metastatic spread.
And how is this complex organ controlled, the innervation?
It has dual control, sympathetic and parasympathetic nerves. The sympathetic pathway comes from the cervical and thoracic sympathetic trunks, sending branches along the way. The greater and lesser splanchnic nerves supply the distal thoracic part. And the parasympathetic pathway comes primarily from the vagus nerve, which sounds incredibly important given its reach.
It is absolutely vital. The vagus nerve gives rise to the superior and recurrent laryngeal nerves high up. The superior laryngeal nerve branches handle motor control for some pharyngeal muscles and sensation in the larynx. The recurrent laryngeal nerves are fascinating. They have distinct loops. The right one loops under the subclavian artery, the left loops under the aortic arch.
Wow.
Before traveling back up in the tracheo-esophageal groove to innervate the cervical esophagus, including that important criciferiндus muscle at the UES.
And I've definitely heard about injuries to those nerves causing problems.
Yes, indeed. Unilateral injury to the superior or recurrent laryngeal nerve results in hoarseness and aspiration from laryngeal and UES dysfunction. It directly impacts speaking and safe swallowing. Lower down, in the thorax, the vagus sends fibers to both the striated muscle up top and provides preganglionic parasympathetic fibers to the smooth muscle below, forming a web-like nervous plexus.
And these connect to those intrinsic plexuses.
Exactly. These nerve fibers penetrate the wall to synapse with the Auerbach plexus between the muscle layers and the Meissner plexus in the submucosa. These form that intrinsic autonomic nervous system we talked about, absolutely crucial for generating peristalsis. Finally, these parasympathetic fibers from the vagus nerves coalesce, usually about 2 centimeters above the diaphragm, into the anterior, or left, and posterior, or right vagus nerves, which then continue down to supply the stomach and other abdominal organs via the celiac plexus.
It truly is a marvel of biological engineering. Okay, here's where it gets really interesting, I think. Moving from the blueprint, the anatomy, to the action, the physiology, The famous architect Louis Sullivan coined the phrase form follows function. And for the esophagus, that seems perfectly illustrated. Its primary job, of course, transport material effortlessly pharynx to stomach, but secondary roles too. Constrain swallowed air, prevent reflux.
That's spot on. Its form has really evolved nicely to function seamlessly. Think about those sphincters again. The UES, about 4 to 5 centimeters long, maintains a mean resting tone of around 60 millimeter Hg. That's tight enough to prevent a steady flow of air into the esophagus as you breathe.
Avoiding constant belching, essentially.
Exactly. And the LES at the other end has a mean resting tone of about 24 millimeter Hg. Just enough pressure to prevent excessive material from refluxing back up from the stomach. This whole process, food from mouth to stomach, is just a masterclass in coordination, demanding precisely timed peristaltic contractions.
And that coordination starts with swallowing. 3 phases: oral, pharyngeal, and esophageal. That pharyngeal phase sounds particularly rapid and complex.
It certainly is. It's a rapid series of events lasting only about 1.5 seconds. And once it starts, it's completely reflexive. You can't stop it mid-swallow.
Like a cascade.
Precisely. 6 key things happen almost simultaneously. 1, elevation of the tongue mixes food with saliva, pushes it back. 2, posterior movement of the tongue thrusts that bolus into the hypopharynx. 3, elevation of the soft palate closes off the nasopharynx so food doesn't go up your nose.
Crucial.
4, elevation of the hyoid bone, that U-shaped bone in your neck, moves up and forward, helping tuck the epiglottis under the tongue. 5, elevation of the larynx, the voice box. This also opens the space behind the larynx and helps the epiglottis cover the airway. And 6, the tilting of the epiglottis itself, that little flap, covers the larynx opening, preventing aspiration, food going down the wrong pipe. It's remarkable lightning-fast coordination.
So once that incredible pharyngeal phase is done, the esophageal phase kicks in.
Yeah.
How do the UES and LES play their parts here?
Okay, so in the esophageal phase, the UES, that upper gate, relaxes to let the food bolus pass, propelled by those pharyngeal constrictors. There's also this clever pressure differential positive pressure in the neck part of the esophagus, combined with the negative pressure in your chest cavity, effectively sucks the bolus into the thoracic esophagus.
Ah, interesting.
Then the UES closes fast within half a second, snapping shut to about 90 millimeter Hg in what's called a post-relaxation contraction. This lasts just milliseconds.
And why so fast?
That immediate closure does 2 things. It initiates the wave of peristalsis down the esophagus, and critically, it prevents reflux back up into the pharynx. Then the UES pressure returns to its resting 60 millimeter Hg, ready for the next swallow.
And then come the waves of peristalsis pushing the food along. There are 3 types, right? Primary, secondary, and tertiary contraction.
Yes. Primary contractions are the main event. These are progressive, organized waves moving at 2 to 4 centimeter seconds, reaching the LES in about 9 seconds. They generate decent pressure, 40-80 millimeter Hg, pushing the food down.
What about rapid swallowing?
Good question. If you take sequential swallows quickly, the esophagus actually stays relaxed until the very last swallow, and then the primary peristaltic wave follows.
Okay. And secondary contractions?
Secondary contractions are also progressive waves, but they aren't triggered by a voluntary swallow. They're generated by distension or irritation within the esophagus itself, like a local reflex to clear any leftover bits.
Like a cleanup crew.
Exactly. And then you have tertiary contractions. These are the problematic ones. They're non-progressive, non-peristaltic, monophasic, or multiphasic simultaneous waves, meaning they're uncoordinated simultaneous squeezes of the smooth muscle. They can happen spontaneously or after swallowing, and these are directly responsible for esophageal spasm.
So that's the mechanism behind spasm.
Okay, and the final phase involves the LES. You mentioned earlier, it's not a true sphincter, anatomically speaking, but it's defined by that high pressure zone. That's right. It's a zone about 2 to 5 centimeters long with a resting pressure between 6 and 26 millimeters Hg. For it to work properly and prevent reflux, it needs a minimum total length of 2 centimeters, with at least 1 centimeter of that located within the abdomen below the diaphragm.
And there's a way to measure that location.
Yes, on manometry tracings, there's the respiratory inversion point, or RIP. That's the spot where the pressure flips from negative, typical of the chest, to positive, typical of the abdomen as you breathe in. It helps pinpoint the LES location. Now, crucially, those peristaltic contractions pushing food down aren't actually strong enough on their own to force open the LES.
Really?
Yeah. Instead, you need vagal-mediated relaxation signals from the vagus nerve telling the LES to relax. This happens about 1.5 to 2.5 seconds after the pharyngeal swallow starts, and the relaxation lasts 4 to 6 seconds. It's flawlessly timed for efficient food passage.
And then it closes again.
Right. After the bolus passes, a post-relaxation contraction quickly brings the LES back to its baseline pressure, reestablishing that vital barrier against reflux.
So if this incredibly complex and coordinated system isn't working perfectly, that's when we start seeing reflux. But our source makes an important point. Not all reflux is abnormal. Healthy people can have occasional spontaneous opening of the LES. So what's the difference between normal reflux and problematic GERD?
That's a great question, and it's a common point of confusion. The competence of the LES, its ability to act as a barrier, depends on several things. Adequate pressure and length, radial symmetry, meaning it closes evenly all around, and the coordinated motility of both the esophagus and stomach.
Okay.
A truly competent sphincter, one that works well, is at least 2 centimeters long and carries a pressure between 6 and 26 millimeter Hg. When there's radial asymmetry, maybe it doesn't close tightly on one side, or abnormal peristalsis, it prevents proper closure, letting stomach contents reflux back up. Plus, abnormal esophageal motility and poor gastric emptying also contribute because they lead to inadequate esophageal clearance. The esophagus can't effectively push reflux stuff back down.
And other factors.
Yeah, finally, various neurotransmitters, hormones, and peptides can also alter the LES tone, making it weaker. All these anatomic and physiologic disruptions can result in reflux through the LES and are implicated in the development of gastro-oesophageal reflux disease, GERD.
Okay, that brings us neatly to our next major section, navigating dysfunction. Let's talk about the diagnosis and management of these esophageal motility disorders. They're described as relatively rare, and often their causes are poorly understood. Symptoms can be quite vague too. Dysphagia, difficulty swallowing, chest pain, heartburn, regurgitation, even weight loss.
Yeah, with those often nonspecific symptoms, diagnosis really relies heavily on manometric findings that exceed 2 standard deviations from normal. Manometry measures the pressures inside the esophagus as you swallow.
The symptoms don't always match the findings.
Exactly. It's worth noting that symptom severity does not always correlate well with manometry, which can definitely complicate treatment planning, especially if you're considering surgery. The gold standard for classifying these disorders today is the Chicago classification. It's purely based on differentiating patterns of manometric findings that we get from high-resolution manometry, HRM, with esophageal pressure topography.
So what exactly is the difference between high-resolution manometry, HRM, and the older conventional manometry?
In conventional manometry, the pressure sensors along the catheter were spaced relatively far apart. With HRM, the sensors are much closer, less than 1 centimeter apart, and you can have up to 36 sensors distributed both radially around the circumference and longitudinally along the length.
Wow, that's a lot of sensors.
It is. And this setup creates a really detailed three-dimensional spatial pressure map of the esophagus during swallowing. That's the esophageal pressure topography part. It gives a much more comprehensive and nuanced picture of exactly how the esophagus is contracting, letting us pick up subtle abnormalities that conventional manometry might miss.
But even with sophisticated HRM, it sounds like a comprehensive workup is still vital because of those vague symptoms.
Absolutely essential. The workup has to include carefully ruling out symptoms coming from other places, cardiac issues, respiratory problems, peptic ulcers, pancreatic or biliary conditions.
Right.
It's also critical to screen for systemic connective tissue disorders like scleroderma because their management, especially surgical management, requires specific modifications to avoid disastrous outcomes. For the esophagus itself, a barium esophagram, the swallow study, is still a highly useful roadmap to see structure and function. A timed barium esophagram is particularly good for evaluating emptying, especially if you suspect achalasia.
And endoscopy.
Upper endoscopy is essential to rule out mucosal abnormalities, inflammation, ulcers, Barrett's, and to visualize any structural defects like strictures, hernias, diverticular, or importantly, masses or tumors. A CT scan isn't always needed, but can be helpful if you suspect something outside the esophagus is pressing on it, an extrinsic cause. And pH testing is usually reserved for cases where the motility disorder is thought to be the result of end-stage GOD.
Okay, so while there are traditional classifications like primary and secondary causes, you mentioned an anatomic approach is often more practical for guiding treatment. Can you elaborate?
Yeah. Traditionally, we talk about primary disorders like achalasia, DES, nutcracker esophagus, hypertensive LES, IEM, where the problem originates in the esophagus itself. And secondary conditions arise from other diseases like scleroderma or Chagas disease. While understanding the underlying cause is important, for practical clinical decision making, especially regarding surgery, an anatomic approach, classifying disorders based on whether they primarily affect the esophageal body or the LES, is often more useful. It helps interpret the manometry results and directly guides the surgical strategy.
Okay, let's start with motility disorders primarily affecting the esophageal body. First up, diffuse esophageal spasm, or DES, now often called distal esophageal spasm under the Chicago classification. It's described as a poorly understood hypermotility disorder, and it's much less common than achalasia, often seen in women with multiple other medical issues.
That's right. The exact neuromuscular cause is still largely unclear, but the basic problem is a motor abnormality in the lower two-thirds, the smooth muscle part of the esophagus. In some patients, you might see muscular hypertrophy, thickened muscle, and even some vagus nerve degeneration. Instead of normal progressive peristalsis, the wave moving smoothly down, DES contractions are repetitive, simultaneous, and of high amplitude.
Meaning the muscles squeeze too hard all at once.
Exactly, very uncoordinated. Clinically, patients get chest pain and dysphagia, difficulty swallowing. The chest pain can actually mimic angina, radiating to the jaw, arms, or back. And these symptoms are often pronounced during times of heightened emotional stress.
Interesting link to stress.
Yeah, regurgitation of food or saliva is common. While acid reflux isn't usually the cause of DES, it can certainly aggravate the symptoms if it's also present. Cold liquids also tend to trigger or worsen things. And interestingly, DES often co-occurs with other functional GI complaints, like IBS, and can sometimes even be triggered by other GI problems like gallstones or pancreatitis.
So how is DES diagnosed, and what does treatment look like, given that relief is often only partial?
Diagnosis is mainly through radiographic studies, the barium swallow, and manometry. On the esophagram, especially in more advanced cases, you might see the classic corkscrew esophagus or pseudodiverticulosis, these little outpouchings caused by the uncoordinated tertiary contractions.
Corkscrew esophagus, visually descriptive.
It is. Manometrically, using HRM and the Chicago classification, DES is defined by a normal median IRP, meaning the LES still relaxes okay, but with 20% premature contractions, and a distal contractile integral, DCI, greater than 450 millimeter HE POSA decimeter. Remember, DCI measures the force of contraction. If the patient's symptoms correlate with drug-induced spasm seen on manometry, that's pretty convincing evidence.
And treatment, non-surgical is the mainstay, you said.
Yes, pharmacologic or endoscopic interventions are usually tried first, given that stress link, psychiatric evaluation, and managing anxiety or depression can sometimes be helpful, even just reassurance. Dietary changes like avoiding trigger foods and acid suppression if reflux is a factor are also recommended. Pharmacologically, nitrates, calcium channel blockers, sedatives, anticholinergics have all been tried, but their long-term efficacy is often limited or unknown. Peppermint oil can sometimes offer temporary relief as a muscle relaxant.
Or endoscopic options.
Endoscopically, bougie dilatation, stretching the esophagus with dilators up to 50 or 60 French, is surprisingly effective for severe dysphagia in about 70–80% of cases. Botulinum toxin, Botox injections into the spastic muscle can provide temporary relief by paralyzing it, but it's not a sustainable long-term fix.
So surgery is really reserved for severe refractory cases.
Correct. Surgery is for patients with incapacitating chest pain or dysphagia that just hasn't responded to medical or endoscopic therapy, or if they develop a pulsion diverticulum. The traditional operation is a long esophagomyotomy.
Myotomy meaning cutting the muscle.
Exactly. Surgically cutting the outer muscle layers of the esophagus. The cut needs to extend high enough to cover the area of abnormal motility, determined by manometry, and distally down onto the LES. A door fundoplication, that partial wrap, is often added to prevent reflux after weakening the LES. Results can be variable, but symptom relief is reported in up to 80% of patients.
And the newer endoscopic approach, POEM.
Yes, peroral endoscopic myotomy, POEM, is emerging with early promising results. It's less invasive. An endoscope is used to make an incision in the inner lining, tunnel under it, and then divide the circular muscle layer from the inside. It's essentially doing the myotomy via a natural orifice. Early studies, though still small for DES specifically, show high clinical response rates and normalization of manometry findings. It's a very exciting development.
Okay, next, nutcracker esophagus, now often called hypertractile or jackhammer esophagus. This one sounds particularly painful.
It often is, yes. It's characterized by excessive contractility or high-amplitude peristaltic contractions. It's widely considered the most painful of these motility disorders. It's actually the most common hypermotility disorder, seen across ages, equal genders, though its exact cause isn't well understood. It's often associated with hypertrophic or thickened musculature.
Symptoms similar to DES.
Similar, yes. Severe chest pain and dysphagia, feeling like food is stuck. Odonophagia, painful swallowing, is also noted. Unlike G. Arior, though, regurgitation and acid reflux are generally uncommon with nutcracker.
And diagnosis and treatment.
The esophagram might be completely normal, as it's a functional pressure issue. Diagnosis by Chicago classification requires subjective chest pain plus manometry, showing at least 2 swallows with a very high DCI, greater than 8,000 millimeter HGSC, but with normal LES pressure and relaxation. Ambulatory monitoring can help distinguish it from DES. Treatment, initially, is primarily medical. Calcium channel blockers, nitrates, antispasmodics might offer some temporary relief. Bougie dietitian can also give temporary relief, but no long-term cure. Avoiding triggers like caffeine, cold, or very hot foods is advised. While surgery wasn't traditionally done, POEM is now showing excellent clinical responses here too, prompting experts to rethink this conventional wisdom for managing nutcracker esophagus.
Okay, shifting focus now to motility disorders primarily affecting the lower esophageal sphincter. First, hypertensive lower esophageal sphincter, now termed EGJ outflow obstruction in the Chicago classification. This is where the LES doesn't relax properly, right? An IRP over 15 millimeter HG.
That's right. It signifies ineffective relaxation at the gastro-oesophageal junction. Some experts think of this as potentially being achalasia in evolution, but the key difference is that patients with EGJ outflow obstruction still have evidence of effective peristalsis in the esophageal body, whereas true achalasia involves absent peristalsis, often dysphagia and chest pain, less frequently heartburn or regurgitation. Diagnosis is made by manometry showing that hypertensive, poorly relaxing sphincter. The respiratory inversion point, RIP, helps localize the LES precisely. Esophageal body motility might be hyperperistaltic or normal in about half the cases. The exact cause isn't well understood.
And treatment options for this outflow obstruction.
Treatment involves both endoscopic and surgical approaches. Botox injections can offer temporary relief. Hydrostatic balloon dilatation, stretching the LES with a balloon, can provide longer-term symptom relief. Surgery is indicated for patients with significant symptoms who don't respond to these. Laparoscopic Heller esophagomyotomy, surgically cutting the LES muscle, is usually the operation of choice. If the patient has normal esophageal body motility, a partial anti-reflux procedure, like a door or toupee wrap, is often added to prevent post-op reflux. And POEM, the endoscopic myotomy, has also been successfully described and studied for this condition, showing good results.
Let's tackle the big one, the condition affecting both the esophageal body and the LES, achalasia. The name itself, failure to relax, tells a big part of the story. It's the best understood motility disorder, you said, with a higher incidence in young women.
That's accurate. Its cause is thought to be either idiopathic, meaning unknown, or possibly related to an infectious neurogenic degeneration. Things like emotional stress, trauma, significant weight loss, even Chagas disease have been implicated in some cases. The primary pathology is the destruction of nerve ganglia within the LES itself. This leads to the LES being hypertensive, too tight, and failing to relax properly during swallowing.
And that affects the rest of the esophagus.
Yes, that outflow obstruction leads to secondary degeneration of the neuromuscular function in the esophageal body. This results in the esophagus pressurizing, dilating over time, and eventually the complete loss of progressive peristalsis.
And it presents with a classic triad of symptoms.
Yes. Dysphagia, difficulty swallowing, regurgitation, and weight loss. Patients also commonly report heartburn-like symptoms, choking after meals, and coughing at night. The dysphagia often starts with liquids and progresses to solids, making eating laborious. Patients often need lots of water just to wash food down.
And the chest pain.
That retrosternal chest pain can be severe, caused by the pressure building up in the dilated esophagus. It's typically only relieved when the LES finally opens a bit. Regurgitation of undigested, often foul-smelling food is very common. And crucially, aspiration food going into the lungs is a major risk, leading to pneumonia, lung abscess, or chronic lung damage like bronchiectasis. It's usually a slow progression over years. Patients adapt, so they often don't seek help until it's quite advanced with marked esophageal distension.
And critically, achalasia isn't just functional. It's also considered a pre-malignant condition.
This is a hugely important point. Over a 20-year period, someone with achalasia has up to an 8% chance of developing esophageal cancer. Squamous cell carcinoma is the most common type, likely due to the chronic irritation from retained fermenting food sitting in the esophagus. Adenocarcinoma can also occur, often in the middle third. Even after treatment for achalasia, there's an ongoing cancer incidence risk. So while there's no universally endorsed screening program, long-term surveillance is strongly recommended.
So how is this serious condition diagnosed definitively?
Manometry is the gold standard. It shows two hallmark findings. A median integrated relaxation pressure, IRP, greater than 15 millimeter Hg, meaning the LES fails to relax adequately, and the complete absence of normal peristalsis in the esophageal body. Other findings might include pressurization of the esophageal body, simultaneous contractions, or low amplitude waves. The Chicago classification further subdivides achalasia into 3 types based on HRM findings, which has prognostic and treatment implications. Type I, classic. High IRP, 100% failed peristalsis, minimal pressurization. Type 2, high IRP, 100% failed peristalsis, but with panesophageal pressurization. In 20% of swallows, the whole esophagus squeezes at once. This type actually tends to respond best to treatment. Type 3, spastic vigorous. High IRP, no normal peristalsis, but shows spastic contractions, high DCI, in 20% swallows. These patients often have more chest pain and can be harder to treat and might represent an earlier phase of the disease.
And what about radiographic findings, the barium swallow for achalasia?
The esophagram is often quite striking. It typically shows a dilated esophagus with that classic bird beak appearance of distal narrowing at the LES. You'll also see signs of sphincter spasm, delayed emptying of the barium, a clear lack of normal peristaltic waves, and often a missing gastric air bubble because the tight LES doesn't let air pass easily into the stomach. In very advanced, long-standing cases, you can see massive esophageal dilatation, tortuosity, where it becomes twisted, and even a sigmoidal esophagus, or megasophagus, where it's so enlarged and elongated it takes on an S shape.
And beyond manometry and esophagram, is endoscopy still needed?
Yes, endoscopy must also be performed in all patients suspected of having achalasia. This is absolutely crucial. Why? To evaluate the lining for inflammation, esophagitis, but more importantly, to rule out secondary causes of distal esophageal narrowing, sometimes called pseudoachalasia.
What could cause pseudoachalasia?
Things like tumors right at the GEJ, certain neuropathies, or even severe strictures can mimic the symptoms and sometimes even the manometric findings of achalasia. You have to rule these out because the treatment is completely different.
Given it's a chronic condition with irreversible motility loss in the body, what are the treatment options? They're palliative, aimed at the obstruction, right?
Exactly. None are able to address the issue of decreased motility in the esophageal body. All treatments aim to relieve the obstruction at the LES. Non-surgical options are often seen as short-term solutions. Medications like sublingual nitroglycerin, nitrates, or calcium channel blockers can offer temporary LES relaxation, maybe some relief in early stages, but usually just for hours. Pneumatic dilatation, using a balloon inflated inside the LES to forcefully stretch and disrupt the muscle fibers, provides excellent relief. However, it often requires multiple sessions over time and carries about a 4% risk of esophageal perforation.
And
Botulinum toxin Botox injections directly into the LES muscle block acetylcholine release, temporarily paralyzing and relaxing the sphincter. It can work for a few months, maybe longer in some older patients, but symptoms recur in over 50% of patients within 6 months, making it mainly a temporary measure or for patients unfit for more invasive procedures. A study comparing dilation and Botox found dilation much more effective at 1 year, 89% offensive, 38% remission.
Okay, so what about surgical options? Surgical esophagomyotomy sounds like a more durable solution.
It generally offers excellent results that are durable. The modified laparoscopic Heller myotomy is the current operation of choice. This involves laparoscopically cutting the outer muscle layers of the LES and a bit up onto the esophagus to relieve the obstruction. Robotic-assisted approaches are also becoming common.
Is an anti-reflux procedure usually added?
That's somewhat controversial, but yes, most patients experience some degree of reflux after a myotomy because you've intentionally weakened the LES. Adding a partial anti-reflux procedure, like a toupee posterior or door anterior fundoplication, helps restore a barrier and significantly reduces postoperative reflux symptoms. A large randomized trial directly compared pneumatic dilatation to Heller myotomy with a door fundoplication. It found equivalent success rates at 2 years, 86% for dilatation versus 90% for surgery. However, the perforation risk was 4% for dilatation, and while Heller had a 12% rate of mucosal tears, all repaired intraoperatively, a quarter of the dilatation patients needed retilation later. Surgery often provides more definitive single intervention relief.
But close monitoring is still needed.
Absolutely. Even after a seemingly successful intervention, clinicians must watch closely because continued asymptomatic outflow obstruction will lead to dilatation and disease progression if not recognized and addressed.
What about PM for achalasia? Is it equivalent to Heller?
POEM is well described for achalasia and has gained significant traction rapidly. It involves endoscopically creating that submucosal tunnel to divide the muscle layer of the distal esophagus, LES, and cardia from the inside. While there were initial concerns about the lack of an inherent anti-reflux mechanism leading to more reflux, early and mid-term results are very encouraging, showing equivalency with Heller myotomy in the short term. Long-term comparative outcomes are still being studied, but it's a very promising, less invasive technique.
And when do things get so severe that esophagectomy, actually removing the esophagus, becomes the only option?
Esophagectomy is reserved for the most difficult cases. A symptomatic patient with a tortuous dilated esophagus, megaesophagus, a sigmoid esophagus, or after the failure of more than one myotomy, or if there's a severe reflux stricture that can't be dilated. Less than 60% of patients benefit from a second myotomy, so at some point a more definitive, albeit major, operation is needed. Besides treating the end-stage achalasia symptoms, esophagectomy also eliminates the risk for carcinoma in the resected area, which is a significant benefit given that premalignant potential. A transhiatal esophagectomy, done through the abdomen and neck without opening the chest, can offer good long-term results. For truly massive megaesophagus, a total esophagectomy incorporating a transthoracic dissection, opening the chest, may be safest to ensure complete removal.
Can POEM even help these end-stage cases?
Interestingly, yes. POEM has also been reported for end-stage achalasia with sigmoid esophagus, with one series showing remarkable 96.8% success at 2 years. This suggests it may obviate the need for esophagectomy even in some of these most challenging scenarios.
Okay, one last motility disorder. Ineffective esophageal motility, or IEM.
Right. IEM, formally recognized around 2000, is primarily a contraction abnormality of the distal esophagus, usually associated with GR defect. It's thought it might be secondary to inflammatory injury from chronic reflex exposure. This dampened motility of the esophageal body leads to poor acid clearance, which can create a vicious cycle, worsening the reflux.
Symptoms are mixed.
Yeah, usually a combination of reflux symptoms and dysphagia, heartburn, chest pain, regurgitation. Diagnosis is by manometry, defined as greater than 50% of swallows being deemed ineffective, meaning their contractile force, DCI, is less than 450 millimeters HGD seismometer. The barium esophagram is usually nonspecific.
Treatment for IEM.
Well, the best treatment is prevention, effectively treating the underlying GERD early on. Unfortunately, once this altered motility develops, it appears to be irreversible in most patients. If IEM is part of scleroderma, then treatment focuses on the underlying condition. For severe, intractable IEM cases not related to scleroderma, surgical approaches must be very carefully tailored and undertaken with great caution due to the low likelihood of a favorable result, as you can't easily fix the fundamental problem of weak muscle contractions.
Okay, let's shift gears now to explore outpouchings and obstructions, specifically diverticular disorders of the esophagus. It sounds like these are often a symptom of something else going on, rather than the primary problem itself.
You're absolutely right. Most diverticula are a result of a primary motor disturbance or an abnormality of the UES or LES. They're classified by location: pharyngoesophageal, that's the Zenker diverticulum, parabronchial, midsophageal, and epiphrenic, supradiaphragmatic, near the bottom.
And there's a difference between true and false diverticula.
Yes. True diverticula involve all layers of the esophageal wall, mucosa, submucosa, and muscularis. These are typically traction diverticula caused by external inflammation, usually from mediastinal lymph nodes sticking to the esophagus. As they heal and contract, they physically pull out all layers of the wall. These are most common in the midsophageal area.
And false diverticula are the pulsion type.
Exactly. False diverticula consist only of the inner layers, the mucosa and submucosa herniating out through a weakness in the muscle layer. These happen because of elevated intraluminal pressures generated from abnormal motility disorders, basically. High pressure from inside pushes the lining out. Both Zenker at the top and epiphrenic at the bottom diverticula are typically pulsion or false diverticula.
Let's start with the pharyngoesophageal diverticulum, described as the most common esophageal diverticulum.
It usually affects older patients, often in their 70s. It's thought to be partly due to a loss of tissue elasticity and muscle tone with age. It specifically herniates from Killian triangle, that area of muscular weakness we talked about earlier, between the thyropharyngeus and cricopharyngeus muscles at the very top of the esophagus.
And it grows downwards.
Yes, as it enlarges, the mucosal and submucosal layers dissect downwards, often along the left side, potentially extending into the superior mediastinum, posteriorly along the prevertebral space. It's sometimes called cricopharyngeal achalasia because the underlying issue is often UES dysfunction or spasm.
What are the typical symptoms and what are the risks?
Initially, they can be asymptomatic. A common early symptom is a feeling of sticking in the throat. As it progresses, patients might develop a nagging cough, excessive salivation, or intermittent dysphagia. When the sac gets large, they often experience regurgitation of foul-smelling, undigested material hours after eating, leading to halitosis, bad breath, voice changes, or retrosternal pain. Respiratory infections are common, and the most serious complication is aspiration pneumonia, or even a lung abscess from regurgitated material entering the lungs. This can be morbid and sometimes fatal, especially in older adults.
How is it diagnosed and what's the gold standard for treatment?
Diagnosis is primarily by barium esophagram. That's the gold standard. It clearly shows the diverticulum filled with barium, usually resting posteriorly, and often reveals a cricopharyngeal bar, an indentation from the tight muscle. Lateral views are critical for seeing the full extent. Manometry and endoscopy aren't usually needed just for diagnosis. Treatment is either surgical or endoscopic repair. The traditional open repair is done through a left neck incision. Options include diverticulectomy, removing the sac, or diverticulopexy, suspending the sac. Critically, in all open repairs, a myotomy cutting the muscle of the proximal distal thyropharyngeus and cricopharyngeus muscles is performed to address the underlying UES dysfunction.
Does the size matter for which open approach?
Yes. For small diverticula, 2 centimeters, a myotomy alone might be enough. For large sacs, 5 centimeters, or if the tissue is good, excision, diverticulectomy, is often indicated. If doing a diverticulopexy, the sac is sutured upwards to the posterior pharynx, not the prevertebral fascia, to allow free vertical movement during swallowing. Post-op stay is usually 2-30 days, often NPO, nothing by mouth initially.
And what about the more popular endoscopic approach for Zenkers?
The endoscopic Dolman procedure is definitely gaining popularity. It involves endoscopically dividing the common wall between the esophagus and the diverticulum using a laser, electrocautery, or most commonly now, a stapler. The stapler works well for larger diverticula, though there's a risk of incomplete myotomy for sacs smaller than 3 centimeters.
How does dividing the wall help?
It essentially divides the distal cricopharyngeus muscle, obliterates the pouch by making it part of the main channel, forming a common pathway for food. It requires maximal neck extension, which can be tough for older patients with neck issues, leading some to use flexible endoscopy with a needle knife for the myotomy instead. The big advantage is a much shorter post-op course liquids the next day, often just an overnight hospital stay. It's generally favored for diverticula between 2 to 5 centimeters. Meta-analyses show it's well tolerated with low adverse event and recurrence rates, and results are generally excellent.
Okay, moving down to mid-esophageal diverticula. Historically, these were often linked to TB.
That's right. Inflamed mediastinal lymph nodes from tuberculosis used to be a common cause. Nowadays, histoplasmosis and fibrosing mediastinitis are more common culprits for these traction diverticula, where external inflammation pulls the wall out. However, it's now believed some mediasophageal diverticula are actually due to an underlying primary motility disorder, like achalasia or DES pushing the lining out, pulsion.
Are they usually symptomatic?
Most are actually asymptomatic and found incidentally. When symptoms do occur, dysphagia, chest pain, regurgitation, they usually point towards that underlying motility disorder needing investigation. A chronic cough might raise suspicion for a bronchoesophageal fistula, a connection to the airway, and very rarely, hemoptysis, coughing blood, could indicate infection eroding into a vessel.
How are these diagnosed and treated?
Barium esophagram is key for showing the anatomy, size, location. They're typically on the right side because major structures are on the left. A CT scan can help identify associated mediastinal lymphadenopathy. Endoscopy is important to rule out cancer or identify a fistula. Critically, manometric studies are undertaken in all patients, symptomatic or not, to find any primary motor disorder, as treatment is heavily guided by these findings. For asymptomatic patients with inflamed nodes, you treat the underlying cause, like histoplasmosis. Small diverticula, 2 centimeters, can often just be observed. If it's symptomatic, or 2 centimeters or larger, surgical intervention is indicated. These are often wide-mouthed and near the spine. Options include diverticulopexy, suspending it from vertebral fascia, or diverticulectomy, carefully removing it. If there's significant pain dysphagia and a documented motor abnormality, a long esophageal myotomy is also indicated.
And finally, epiphrenic diverticula, found right near the diaphragm.
Yes, in the distal third, usually within 10 centimeters of the GEJ. These are pulsion false diverticula. They're often related to thickened distal esophageal musculature or increased intraliminal pressure from associated motility disorders like DES, achalasia, or hypertensive LES. If no motility issue is found, congenital causes like Ehlers-Danlos or trauma are considered. They occur more often on the right side and tend to be wide-mouthed.
Symptoms similar to mesophageal ones.
Very similar. Most are asymptomatic incidental findings. Dysphagia or chest pain usually indicates the underlying motility disturbance. If the motility problem is advanced, the diverticulum can become quite large, leading to symptoms like regurgitation, epigastric pain, anorexia, weight loss, chronic cough, and halitosis.
So diagnosis and treatment follow a similar pattern.
Largely, yes. Barium esophagram is the best diagnostic tool, showing size, position, and often suggesting the underlying motility disorder. Manometric studies are essential to assess body and LES function. Endoscopy checks for mucosal lesions, esophagitis, Barrett's, or cancer. Treatment is similar to midesophageal ones. Small ones, 2 centimeters, might be suspended, diverticulopexy, along with a myotomy from the diverticulum neck down onto the LES. If excised, diverticulectomy, usually with a vertical stapler, an esophageal bougie inside is essential to avoid narrowing the lumen. The muscle is closed over the excision site. Crucially, a long myotomy is performed on the opposite esophageal wall, from the diverticulum level down onto the LES to address the underlying pressure.
What if there's also a hiatal hernia?
Good point. If a hiatal hernia is present, it must be repaired, along with the diverticulum excision and myotomy. Failure to repair results in a high incidence of postoperative reflux. The key principle is that it's essential to relieve outflow obstruction. Otherwise, the repair can leak or the diverticulum can recur. Minimally invasive techniques, laparoscopy or thoracoscopy, are now safely approached with excellent outcomes and improved quality of life.
It's fascinating how consistently these outpouchings are linked back to underlying pressure or motility issues.
Yeah.
It really highlights that the diverticulum is often the symptom, not the root cause.
Precisely. Addressing that underlying functional problem, the pressure, the spasm, the poor relaxation, is paramount for successful long-term treatment and preventing recurrence.
Okay, our next big topic is one that affects millions. The burden of reflux. Gastro-oesophageal reflux disease, or GERD.
It truly is the most common benign condition of the esophagus. Simply put, it's the retrograde flow of gastric contents back up through the LES. Typical symptoms are heartburn, the most common regurgitation, and sometimes dysphagia.
And it tends to get worse over time.
Yes, the disease is often characterized by a progressive worsening of symptoms until they are frequent, persistent, and troublesome, really impacting daily life.
And the complications can be quite serious, can't they?
Absolutely. Long-standing, poorly controlled GER can lead to a whole cascade of problems. Strictures, which are narrowings, ulcers in the esophagus, metaplasia, like Barrett esophagus, where the lining changes, dysplasia, which are precancerous cell changes, and even outright carcinoma or cancer. Beyond the esophagus, chronic aspiration of stomach contents can contribute to pulmonary issues like asthma, chronic cough, or lung fibrosis.
But treatment has improved.
Significantly. We have much better anti-secretory medications now, like proton pump inhibitors, PPIs, and surgical techniques have been greatly refined. Many patients can be managed very well medically with drugs and lifestyle changes. Surgery becomes an option for those with refractory symptoms despite maximal medical therapy or for complications that can't be treated otherwise.
Let's talk about medical management first. When do patients typically get referred for surgical consideration?
Most surgical referrals happen because of uncontrolled, persistent heartburn or regurgitation, despite being on maximal medical therapy. That usually means trying different PPIs, often twice a day, plus antacids, without getting adequate relief. Or, if stopping their PPI leads to prohibitive symptoms, they just can't function without it, that's a strong indicator for surgical evaluation.
What about atypical symptoms?
That's crucial. Patients with atypical symptoms, chronic cough, hoarseness, asthma exacerbations, non-cardiac chest pain, need to be further investigated for other causes before jumping to reflux surgery. Their symptoms might not be solely due to GERD. The patients who generally have the greatest likelihood of successful surgical therapy are those who have typical symptoms: heartburn, regurgitation, and a good response to anti-secretory therapy, because that confirms their symptoms are acid-related.
And lifestyle modifications, how much do they help on their own?
They rarely eliminate symptoms entirely for significant GRD, but they can definitely decrease severity and duration, and often increase medication efficacy. Things like losing weight if overweight, stopping smoking, avoiding trigger foods, fatty meals, chocolate, caffeine, mint, eating smaller meals, stopping alcohol, and treating constipation can all help. But it's important to remember that for persistent GRD, medical therapy is usually considered maximal with twice-daily PPI therapy.
Before even considering surgery, a comprehensive workup sounds absolutely essential to make sure the right patient gets the right procedure.
It is critical for successful selection of therapy and, just as importantly, for avoiding complications. The standard preoperative studies usually include pH testing, esophageal manometry, video esophagram, and upper endoscopy with biopsy.
Can you break down what each test tells us?
Sure. pH testing acts as a surrogate for acid reflux. It directly measures and documents the amount of acid exposure in the distal esophagus over 24-48 hours, while the patient is off acid-suppressing meds. It helps correlate symptoms with acid events. A Demeester score greater than 14.72 confirms pathologic GERD and correlates strongly with good surgical outcomes. Esophageal manometry evaluates the strength of peristalsis, checks for underlying motility disorders like achalasia or scleroderma, which would drastically change surgical plans, and assesses LES incompetence, low pressure, short length. It allows for tailoring the surgery, maybe a partial wrap if motility is weak. Patients with long-standing GERD often develop dysmotility, so they need counseling about potential post-op dysphagia. Severe dysmotility might even lead to recommending further workup or non-surgical therapy. Video esophagram, the barium swallow, shows both structure and function dynamically. It's the roadmap. It diagnoses things that might modify surgery, like strictures, masses, large hiatal hernias, a foreshortened esophagus, or diverticula. It can also confirm reflux visually and suggest motility disorders. An upper endoscopy with biopsy allows direct visualization. You check the esophageal shape, look for signs of reflex damage like esophagitis or metaplasia, Barrett's, and crucially rule out masses or strictures. You can see hiatal hernias on retroflex views. Biopsies of any abnormal findings or vital findings, significant dysplasia or cancer, obviously alters the entire plan.
What happens if these results don't all point the same way? Or if the symptoms are atypical despite some positive findings?
That's a red flag. If there are inconsistencies, it's really important to revise the diagnosis, to continue investigation, or to obtain second opinions. Giving someone reflux surgery for symptoms caused by something else can lead to new problems without fixing the original complaint. Surgeons should be especially wary with atypical symptoms or if the patient gets zero relief from PPIs. The strong recommendation is for confirmation of pathologic acid reflux with at least 2 objective tests prior to offering entire flex surgery. Sometimes adjunct studies like CT scans, gastric emptying studies, or even a colonoscopy might be needed.
Okay, moving to surgical therapy itself. The source focuses on transabdominal fundoplication. What are the core principles surgeons follow for these anti-reflux procedures?
Regardless of the specific type of wrap they do, there are 5 core tenets that remain constant for a good, lasting outcome. 1. Always preserve natural tissue planes and linings to minimize scarring and keep the anatomy as normal as possible. 2. Identify and preserve both vagus nerves. Damaging them can severely affect gastric emptying and other functions. 3. Identify the true EGJ for placement of the wrap. Getting the rep in the right spot is crucial. 4. Ensure you have sufficient length of intra-abdominal esophagus, usually 2-3 centimeters, so the wrap isn't under tension. And 5. Reestablish the angle of his, that natural sharp angle where the esophagus joins the stomach, which itself provides some anti-reflux barrier.
The Nissen fundoplication is described as the standard in anti-reflux surgery. How exactly does that work? What's involved?
Right. The Nissen is a complete 360-degree wrap of the fundus, the top part of the stomach, around the very distal esophagus, essentially creating a new reinforcing sphincter. The procedure involves several key steps. First, incising the gastrohepatic ligament carefully, watching out for any replaced hepatic arteries that sometimes run there. Then, circumferentially mobilizing the distal esophagus, meticulously preserving the vagus nerves and the peritoneal lining. The short gastric vessels supplying the fundus are usually divided to allow the fundus to reach around without tension. Any hiatal hernia sac is dissected free, bringing enough esophageal length down into the abdomen, aiming for that at least 2 to 3 centimeters of intra-abdominal esophagus. The gastro-esophageal fat pad is mobilized to clearly visualize the true GEJ, making sure the vagus nerves are safely out of the way. The diaphragmatic hiatus, the opening in the diaphragm, is then assessed and usually closed posteriorly with sutures to prevent the wrap from herniating back into the chest, but not so tight as to kink the esophagus. Then the mobilized fundic tip is passed posterior to the esophagus, again making sure the vagus is excluded. A shoe shine maneuver, gently pulling the wrap back and forth, confirms mobility and lack of tension. A large bougie, like a 50-54 French dilator, is placed temporarily inside the esophagus while the wrap edges are sutured together anteriorly, incorporating a small bite of the anterior esophageal wall.
And post-op care.
Postoperatively, it's important that antiemetics are administered liberally to avoid retching or emesis, as this may disrupt the repair in the early stages. Using mesh to reinforce the hiatal closure is generally not usually necessary if the natural peritoneal linings are preserved, but it might be considered if there's excessive tension or very weak tissues. Surgeons might also use techniques like reducing CO2 pressure during laparoscopy or making relaxing incisions to reduce tension on the closure. It's also individualized, leaving a bit of space between the wrap and the esophagus, enough for an instrument to pass, can help reduce postoperative dysphagia and gas bloat. And in specific situations, like for lung transplant patients where preventing any aspiration is paramount, a snug 360-degree wrap might be intentionally desired.
And there are variations of the Nissen, partial wraps, tailored to individual patient needs.
Yes, absolutely. Recognizing that a full 360 wrap might be too tight for some patients, especially those with pre-existing swallowing issues. The two-peg fundoplication is a posterior partial wrap, typically 270 degrees, where the wrap edges are sutured to the diaphragm crura. The door fundoplication is an anterior 180-200 degree wrap, and it's the one most commonly used when performing an esophageal myotomy, like for achalasia, because it provides good reflux control while buttressing the myotomy site.
Why choose a partial wrap?
Partial wraps are often preferred for patients who already have significant dysphagia before surgery or those found to have poor esophageal peristalsis on manometry. This is because postoperative dysphagia is a major reason people need reoperation after a Nissen. However, even with careful technique and tailoring, the rate of recurrent GORD is not insignificant. One study showed 17.7% recurrence at a median of 5.6 years. This really highlights the critical importance of appropriate patient selection and potentially ongoing medical therapy even after surgery.
What about newer devices? You hear about things like the LINX device.
The LINX device is a really interesting newer option. It's essentially a small, flexible ring of interlinked titanium beads with magnetic cores. This ring is placed surgically around the outside of the GEJ. The magnetic attraction between the beads keeps the LES closed at rest, preventing reflux. But when you swallow, the pressure of the food bolus is enough to stretch the beads apart, allowing passage, and then they snap closed again, mimicking the natural LES function.
Those are fun.
It was initially used mainly for patients with minimal or no hiatal hernia, but recent studies report good outcomes even with hiatal hernias over 3 centimeters. Studies show promising results. Nearly 2/3 reduction in acid exposure and over 90% improvement in quality of life and PPI use at 1 year. 5-year data shows excellent reflux control with no device erosions or migrations. Compared to fundoplication, it seems to offer similar QOL improvements, but with significantly less bothersome side effects like regurgitation and gas bloat and lower ongoing PPI use. Long-term comparative studies are still needed, but it's a rapidly growing alternative.
And for really complex situations, like severe bile reflux or patients with morbid obesity.
For patients with significant non-acid, like bile reflux, especially after previous stomach surgery, or for those with morbid obesity, diabetes, or severe esophageal dysmotility where a wrap might not work well, Roux-en-Y reconstruction is a major alternative. This involves creating a near esophagogynostomy, essentially connecting the esophagus further down the small intestine, the duodenum, and rerouting the stomach and bile flow so contents pass far downstream, effectively preventing anything from refluxing back up into the esophagus.
And it helps with obesity, diabetes, too.
Yes, it has significant metabolic benefits for those conditions as well. It's also often the go-to option for revisional surgery where there's extensive scarring or the vagus nerves might have been compromised in previous operations.
And what if the esophagus itself is just too short to get enough length into the abdomen for a safe, tension-free wrap?
That's a critical challenge, often seen with large, long-standing hiatal hernias. That's where a callus gastroplasty or esophageal lengthening procedure comes in. This involves surgically creating a tube out of the upper stomach, the fundus, essentially a wedge fundectomy, using a stapler over a bougie inside the esophagus. This creates a few centimeters of neoesophageal length made of stomach tube.
Then you wrap that.
Exactly. This newly created neoesophagus can then be used to perform a proper, tension-free fundoplication wrap below the diaphragm. It's technically more complex, can be done tranthoracically or transabdominally, but it is imperative to realize when it should be done to ensure a successful, durable repair and avoid wrap failure or slippage. One thing to note. Patients who have achalasia often need short-term PPIs postoperatively because that neoesophagus segment is still acid-secreting gastric mucosa that's now positioned above the wrap.
Okay, that covers the standard procedures, but what about complicated GR? What if someone presents with esophagitis or strictures already?
For esophagitis, inflammation of the lining, biopsies are crucial during endoscopy. They might reveal specific medically treatable issues like candidiasis, fungal infection, or eosinophilic esophagitis, which often respond well to targeted medical therapy without needing surgery. For strictures or narrowings, they always need to be biopsied to rule out underlying malignancy. If they're benign, they're frequently managed effectively with endoscopic dilatation, stretching the narrowed area with balloons or bougies. Surgery might still be needed if dilatation fails or isn't durable.
And Barrett esophagus, that precancerous condition, how does that impact surgical decisions?
Intestinal metaplasia, or Barrett esophagus, requires meticulous management and surveillance. The standard is the Seattle biopsy protocol, 4-quadrant biopsies every centimeter, plus targeted biopsies of any visible abnormalities looking for dysplasia, abnormal cell changes, or cancer. Fundoplication is possible and often recommended for patients with Barrett's and refractory GERD symptoms. There's some, albeit controversial, evidence suggesting effective reflux control might lead to histologic regression of Barrett's in some patients. However, the key point is that surveillance endoscopy must continue at regular intervals, even after successful entire flux surgery, because the underlying risk of cancer developing in the Barrett segment remains.
What about really large hiatal hernias, where part or even all of the stomach is up in the chest? That sounds mechanically problematic.
Yes. The workup and surgery for a partial or complete intrathoracic stomach are significantly different from standard GERD. Symptoms can be driven by the mechanical component, the stomach compressing the lungs or heart, or by reflux, and often it's both.
What kind of mechanical symptoms?
Severe dysphagia, food sticking, early satiety, feeling full quickly, regurgitation, chest pain, sometimes even vomiting, especially with very large intrathoracic stomachs. The workup might need to include pulmonary function tests, as lung capacity can be compromised, and a thorough cardiac evaluation. Manometry is often impossible due to the distorted anatomy. Surgically, the esophagus might be significantly foreshortened, making repair challenging. Options range from just reducing the hernia and performing a gastropexy, tacking the stomach down the abdomen, mainly for mechanical relief, though they might still need PPIs for reflux, versus a formal fundoplication, possibly requiring a collis gastroplasty lengthening procedure first to address both the mechanical issue and the reflux. Given that motility is often unknown or impaired in these cases, most surgeons would lean towards a partial fundoplication if doing a wrap to minimize the risk of postoperative dysphagia.
Okay, let's turn our attention now to other acquired benign disorders of the esophagus, starting with esophageal perforation. This sounds like a true medical emergency.
It absolutely is a potentially lethal condition. Outcomes are notoriously poor if there's a delay in diagnosis or improper treatment, with historical mortality rates around 15–30%.
What causes it most often?
The most common cause is iatrogenic, meaning caused by a medical procedure, usually endoscopy. The second most common is forceful retching or vomiting, known as Boerhaave syndrome, which causes a spontaneous tear. Other causes include traumatic injury, swallowing a foreign body, or sometimes erosion from a tumor. The thoracic esophagus, the part in the chest, is involved in about 2/3 of cases.
And time is critical.
Absolutely. Outcomes are significantly better if intervention happens within 24 hours of the injury. Poorer outcomes are also seen with cancer-related perforations, so early recognition with timely diagnosis and therapy is the absolute key.
What are the telltale signs clinicians should look for to suspect the perforation?
Suspicion should be high with symptoms like sudden onset epigastric or chest pain, maybe radiating to the back, neck, or throat pain, and dysphagia, difficulty or pain swallowing. On physical exam, you might find crepitus, that crackling sensation under the skin from escaped air in the chest, neck, or even face. Neck swelling, epigastric tenderness, or a nasal voice change can also occur. But sometimes the physical exam can be deceptively normal, especially early on.
So imaging is crucial.
Yes, early radiographic evidence might show up on a simple chest x-ray. Mediastinal air, air in the center of the chest, cervical air, air in the neck tissues, free air under the diaphragm if the tear extends into the abdomen, or a pleural effusion, fluid around the lung. A CT scan is often more sensitive and can show mediastinal or periesophageal air or fluid collections. The mechanism of injury itself, recent endoscopy, severe vomiting, is often the strongest clue.
How do you definitively confirm the diagnosis?
A barium esophagram, a swallow study using contrast, is traditionally the standard for diagnosis. It directly visualizes the leak. Water-soluble contrast is usually used first, followed by thin barium if the initial study is negative, but suspicion remains high, as barium is more sensitive but can cause more inflammation if it leaks widely. A CT scan with oral contrast is an alternative if an esophagram isn't feasible. If suspicion is very high but these studies are normal, direct laryngoscopy or endoscopy might be needed, but with extreme caution as instrumentation can worsen a small contained tear. There's also a clinical severity score, the Pittsburgh score, that uses factors like age, vital signs, time to diagnosis, and radiographic findings to help predict morbidity and mortality and guide immediate treatment decisions, whether non-operative management might be feasible or if urgent intervention is needed.
So, once diagnosed, what are the core principles of management? Sounds like a multi-pronged attack.
It is. 4 key principles. 1. Treatment of contamination, immediately starting broad-spectrum antibiotics, often including antifungals, as the leakage contains oral and potentially gastric contents. 2. Wide local drainage of any leaked fluid or developing abscesses, typically using chest tubes placed into the pleural space, or sometimes radiologically guided drains for specific collections. If there's significant pleural contamination or a persistent leak, VATS, video-assisted thoracoscopic surgery, or even open thoracic washout and decortication, removing inflammatory peel from the lung, might be needed. 3. Source control, directly addressing the hole in the esophagus itself. And 4. Establishing enteral feeding access, usually a feeding tube placed past the injury, jejunostomy, for nutrition while the esophagus heals.
Okay, let's focus on source control. What are the main approaches to fixing the hole?
It really depends on the patient's overall condition, the size, location, and containment of the perforation, how long ago it happened, and the surgeon's experience. There's been a big shift toward less invasive options recently. Endoluminal therapy with covered stents is increasingly popular and shows good results in appropriately selected patients. A covered stent is placed endoscopically across the perforation, effectively sealing it from the inside and allowing it to heal underneath. Stent migration is a potential issue, so frequent x-rays are needed to check its position. Plastic stents tend to migrate more but cause fewer strictures later compared to metallic stents. Stents are generally considered for early, small, contained perforations in stable patients, or sometimes if there's a significant delay between injury and diagnosis, where the tissues might be too inflamed and friable for a good surgical repair. VATS is often used concurrently with stents for drainage and washout. Stent therapy, possibly combined with VATs, might be as effective as open surgery in some cases, with potentially less morbidity, shorter hospital stays, and lower costs.
And if surgery is necessary, what does that involve?
The surgical approach depends on the leak's location. High cervical perforations are usually accessed via a left neck incision. Esophageal perforations typically require a right thoracotomy, opening the right chest. Distal perforations near the stomach are usually approached via a left thoracotomy or a combined thoraco-abdominal incision. Minimally invasive approaches, VATS or robotic, are also reasonable options in experienced hands. Surgically, the steps involve identifying the perforation, often performing a myotomy, cutting the muscle layer, around the tear to fully expose the mucosal injury, debriding, cleaning away any dead or devitalized tissues, and assessing the full extent. Critically, any sign of obstruction distal to the tear, like underlying achalasia, a stricture, or a tumor, must be remedied at the same time. Otherwise, the perforation simply won't heal due to continued high pressure above it. For example, if achalasia is present, a myotomy on the opposite side might be performed.
How is the hole actually repaired?
For small injuries with healthy surrounding tissues, especially if caught early, a primary repair in 2 layers, mucosa then muscle, is often possible, usually reinforced with a tissue flap like intercostal muscle, pericardial fat, pleura, or omentum brought up from the abdomen for added protection. For extensive tears or devitalized tissue, a primary repair might not hold. In these cases, options include controlled fistulization by T-tube, where a T-shaped drain is placed through the hole to allow controlled drainage while it heals, or for very large destructive injuries, sometimes esophageal exclusion is necessary.
Exclusion, what's that?
That means diverting the saliva flow away from the damaged area, usually with a cervical esophagostomy, bringing the upper esophagus out to the neck skin, and placing a gastrostomy tube for stomach drainage, essentially bypassing the injured segment completely, with plans for a major reconstruction later using stomach, colon, or small bowel. Gastrostomy and jejunostomy tubes for decompression and feeding are almost always placed during the initial operation, regardless of the repair type.
Are there any newer endoscopic options besides stents for managing perforations?
Yes, a couple are emerging. Endoscopic vacuum therapy, EVT, involves placing a specialized sponge endoscopically directly into the injury site or cavity. This sponge is connected to an external vacuum source, providing continuous negative pressure. This promotes drainage, helps the wound contract, and encourages granulation tissue formation. Serial endoscopies are needed to monitor healing and exchange the sponge until the mucosa is healed. Also, over-the-scope clips, OTSCs, are large clips deployed endoscopically that can sometimes be used for acutely identified smaller perforations to directly seal the injury.
Do these replace the need for drainage, etc.?
No. It's important to remember that even with EVT or clips, the fundamental principles still apply: adequate drainage of any contamination, decortication if needed, and providing nutritional support are still mandatory. But these techniques offer less invasive options for source control in select cases. Early evidence suggests they are safe and viable options with good outcomes in appropriate scenarios. And encouragingly, overall mortality from esophageal perforation may be decreasing, likely due to the combination of these newer, minimally invasive endoluminal techniques, better imaging, improved critical care, and the trend towards regionalizing these complex cases to high-volume centers with specialized expertise.
Okay, another very serious acquired disorder is caustic ingestion. How do these injuries typically happen, and what determines how bad they are?
Most accidental caustic ingestions, like a child swallowing a small amount of household cleaner, involve small volumes. In adults, however, ingestions are more often intentional, related to suicide attempts, and frequently involve large volumes, leading to much more expensive and severe injury. The injury pattern can range dramatically from just a short segment superficial injury to full thickness necrosis, potentially involving the esophagus, stomach, and even small bowel. Key factors affecting severity are the pH of the substance. Alkalis like lye cause deep liquefactive necrosis, while acids cause more superficial coagulation necrosis, the volume ingested, and the duration of contact.
What's the immediate evaluation and management for such a critical situation? It sounds like airway is paramount.
A surgeon must be involved immediately, and yes, airway is the first priority. Any signs of upper airway compromise, difficulty breathing, dyspnea, drooling, high-pitched breathing sounds, stridor, hoarseness, suggests significant laryngeal swelling and likely necessitate immediate endotracheal intubation. This should ideally be done with bronchoscopic guidance, and the team must be prepared for a potential cricothyroidotomy, surgical airway, because intubation can be extremely difficult or impossible, and there's a high risk of iatrogenic perforation. Critically, nasogastric and orogastric tubes should not be inserted blindly, as this can easily cause further injury or perforate weakened tissue. Initial imaging, ideally a CT scan of the chest and abdomen with both IV and oral contrast, followed potentially by a careful barium swallow, is crucial to assess the extent of internal injury and guide the first procedure.
And endoscopic evaluation, when is that done?
Endoscopic evaluation to directly visualize the injury's extent and severity is recommended early, ideally within the first 12-24 hours. The risk of perforation during endoscopy increases significantly after 48 hours as the damaged tissue softens and becomes more friable. Pediatric endoscopes can sometimes be helpful for initial assessment due to their smaller size. While traditional teaching was to not advance the scope beyond a circumferential injury, one that goes all the way around, an experienced endoscopist might cautiously proceed if it impacts acute management decisions. It's crucial to carefully document the severity and degree of injury at all locations using a standardized classification system, as repeat endoscopies, often at 48-72 hours, are frequently needed to assess for worsening injury. All patients require broad-spectrum antibiotics. Frequent clinical reassessment is paramount. Any signs of deterioration, sepsis, peritonitis warrant immediate further investigation and likely surgical intervention.
What do those surgical interventions entail, and what are the long-term consequences?
Surgical intervention varies widely based on the injury severity. It can range from just observation and supportive care after endoscopy for mild injuries, to placing gastrostomy or jejunostomy tubes for feeding, all the way up to major resections like esophagectomy, gastrectomy, or even small bowel resection if there's full thickness necrosis, often requiring proximal diversion like an esophagostomy. Reconstruction after such extensive resections is complicated, often delayed for months, and typically involves using colon or small bowel conduits to bridge the gap. Long-term issues are significant and life-altering. Severe strictures are very common, often requiring repeated dilations over years and sometimes eventual resection anyway. Fistulas can develop between the esophagus and airway or aorta. And tragically, patients have a greater than 1,000 times increased risk of developing esophageal cancer, usually squamous cell, many years after the initial caustic injury. It's also important to note that routine use of corticosteroids is no longer advocated, as it hasn't shown benefit and may mask complications. Things like early dilation or placing esophageal stents are considered on a case-by-case basis.
Okay, let's quickly touch on a few other benign acquired disorders mentioned. Foreign body ingestion, benign tracheoesophageal fistula, and Chatsky ring.
Right. For foreign body ingestion, especially sharp objects like fish bones or large impacted food boluses, technical expertise is crucial to prevent iatrogenic perforation during removal. If an object is lodged, careful endoscopy under general anesthesia is usually preferred for patient comfort and airway control. Forceful pushing should be strictly avoided. Retrieval often requires specialized tools like large graspers, nets, or snares, along with patience and always maintaining full visualization. Overtubes, which slide over the endoscope to protect the esophagus during removal, and sometimes rigid esophagoscopy can be very useful. If an object simply cannot be retrieved endoscopically, then laparoscopy or laparotomy with gastrotomy, opening the stomach, might be needed. Full GI tract X-rays or CT scans are often done first to locate the object. And importantly, recurrent ingestions or acts of self-harm warrant inpatient psychiatric evaluation.
And benign tracheoesophageal fistula, TEF, a connection between the windpipe and esophagus.
Yes, this is often seen in patients who've had prolonged intubation or tracheostomy, especially with a concurrent nasogastric tube in place. The pressure from cuffs or the tubes themselves can erode through the shared wall. Symptoms most commonly include recurrent or persistent respiratory infections, or sometimes seeing food saliva coming out of a tracheostomy site. Diagnosis is typically with CT scan and barium swallow, followed by both bronchoscopy to evaluate the airway and endoscopy to evaluate the esophagus. Treatment principles involve 1. Discontinuing the causative agent if possible, for example, changing the tracheostomy tube. 2. Considering temporary exclusion of the fistula with a stent or diversion of saliva food. And 3. Planning for definitive repair or allowing for delayed healing. Definitive repair, when the patient is stable, usually involves fistula resection and closure, often with interposition of vascularized tissue, like muscle, between the trachea and esophagus to prevent recurrence, typically done via a thoracotomy or surgical approach. Antibiotics are used. Enteral access, feeding tube, and gastric decompression are essential. Trying to do a definitive repair in a critically ill patient is not optimal. Sometimes, if the offending agents are removed and diversion is successful, the fistula can heal spontaneously over time. Esophageal stents are occasionally used, but kissing stents in both the esophagus and airways simultaneously, are generally reserved for the most moribund patients, as they can paradoxically worsen the fistula. EVT is also being explored here.
And finally, the Chatsky ring. What is that?
This is a relatively common finding. A concentric, non-malignant fibrous thickening narrowing right at the GEJ, the junction of the esophagus and stomach. It typically has squamous epithelium above it and columnar cells below it. The exact cause is unknown, but there's a strong correlation with GE-GAR, and most patients also have a hiatal hernia.
Is it always a problem?
No, the presence of a ring itself isn't pathologic unless it's symptomatic, typically causing intermittent dysphagia, especially for solid foods, or obstruction, steakhouse syndrome. Diagnosis is made by esophagram or endoscopy. Treatment is usually straightforward. Dilatation with either bougies or balloons to stretch the ring open. The area should always be biopsied to rule out malignancy, just in case it's something more serious mimicking a ring. Repeated dilatation is often necessary over time and is considered reasonable long-term management, as there are few permanent surgical fixes. However, persistent strictures should always raise suspicion for malignant disease and warrant reevaluation.
Okay, now we must confront the really serious topic. The oncologic challenge, esophageal cancer. The statistics you mentioned earlier are quite grim.
They are indeed sobering. Nearly 18,000 new cases annually, just in the U.S., around 572,000 worldwide. And because it's typically diagnosed at an advanced stage, the current overall 5-year survival rate is only about 19%. It's a highly aggressive and often deadly cancer.
And the types are changing. Adenocarcinoma is becoming more common here in the West.
Yes, that's a significant trend. There's been a concomitant decline in squamous cell carcinoma, SCC, worldwide, and in the U.S., while adenocarcinoma incidence rose dramatically, particularly linked to the increasing obesity epidemic and GRD contributing to adenocarcinoma. This contrasts with global reductions in cigarette smoking, which is a primary driver for SCC. It seems to be a true increase in adenocarcinoma, not just better detection. Other types of esophageal cancer are much rarer.
What are the main risk factors for each type? Let's start with squamous cell carcinoma, SCC.
For SCC, the big ones are tobacco and alcohol. They have a strong synergistic effect, meaning the combined risk is much higher than either alone. It's also 3-4 times more common in men, and race is a factor, with higher rates in African Americans in the U.S. Globally, certain regions like parts of the Middle East, Central Asia, and China have very high rates, suggesting genetic or strong environmental factors. HPV infection seems related to a small subset, but the clinical implications aren't fully clear yet. SCC is also associated with intrinsic esophageal disorders like Plummer-Vinson syndrome and long-standing achalasia. Certain hereditary cancer syndromes like tylosis also increase risk. And as we mentioned, a history of caustic ingestion significantly increases the long-term risk.
And for adenocarcinoma, that's the one linked to reflux and obesity.
Primarily, yes. Its incidence increased dramatically in the last 4 decades, making it the most common type now in the U.S., although the rate may have stabilized or slightly decreased very recently, except maybe in younger non-Hispanic whites, where it might still be rising. It's uncommon in African Americans. It most often arises within Barrett esophagus, that metaplastic change in the lining caused by chronic reflux. The frequency and duration of GR8 symptoms are significantly associated with risk. There's also a strong male predominance, and some familial forms of Barrett esophagus confer increased risk.
Where do these cancers typically occur in the esophagus?
SCC can arise anywhere, but the majority are found in the proximal or middle third. Adenocarcinoma, on the other hand, is predominantly found in the distal esophagus, or right at the gastro-oesophageal junction, GEJ. Current staging guidelines, AJCC-NCCN, actually stage most GEJ adenocarcinomas as esophageal cancers, unless they are Siewert III tumors, centered 2 to 5 centimeters below the GEJ, which are then classified with gastric cancers.
So when do patients typically become symptomatic? Sounds like often is quite late.
Unfortunately, yes. The majority are symptomatic at diagnosis. Dysphagia, difficulty swallowing, is the most common symptom, and it's usually progressive, starting with solids like bread or meat, then worsening to softer foods, and eventually liquids. Patients often adapt subconsciously, chewing more, eating slower, avoiding certain foods, so they don't seek medical attention until the dysphagia has worsened significantly, and it's often accompanied by unintentional weight loss by that point. Adenocarcinoma patients often have a long history of reflux symptoms preceding the dysphagia. Other symptoms can include fatigue, retrosternal pain behind the breastbone, or anemia from slow bleeding. If locally advanced, it can involve the laryngeal nerve causing hoarseness or even create a tracheoesophageal fistula. Sometimes enlarged lymph nodes in the neck or above the collarbone might be felt. Early-stage tumors, however, are often asymptomatic and are typically found incidentally during surveillance endoscopy for Barrett's.
Once cancer is suspected, accurate diagnosis and staging becomes absolutely critical.
It is essential because it dictates the entire treatment plan and gives prognostic information. A barium esophagram might show an irregular narrowing or ulceration, sometimes the classic apple core defect of circumferential narrowing, or maybe just an asymmetric bulge if it's infiltrating. However, the definitive diagnosis is almost always made by endoscopic biopsy. Endoscopy should be performed for any patient presenting with new dysphagia.
What does the cancer look like on endoscopy?
Appearances vary. It can be a friable ulcerated mass that bleeds easily. Early cancers might just look like subtle ulcerations or small nodules. More advanced tumors often cause significant strictures or large ulcerations. Multiple biopsies of any suspicious lesion are crucial to confirm cancer and determine the type, adenocarcinoma versus SCC.
And the endoscopist documents more than just the presence of cancer, right?
Yes, very important details. They document the tumor's location relative to landmarks like the incisors and the GEJ, the tumor's length, and the degree of obstruction it's causing. If Barrett esophagus is present, its proximal and circumferential extent is documented using the PROG criteria. For small, potentially superficial tumors or nodules, endoscopic mucosal resection, EMR, might be performed right then, not just for treatment, but also for accurate staging. EMR provides larger specimens to accurately determine the depth of invasion, T status, and look for lymphovascular invasion, which helps predict nodal metastasis risk. Endoscopic ultrasound, EUS, has less accuracy for superficial disease compared to EMR, but is better for deeper staging.
And then, that accurate staging becomes the foundation for everything else.
Absolutely essential to guide appropriate therapy and to predict prognosis. The current system is the 8th edition AJCC staging, which importantly has separate groupings for adenocarcinoma and SCC, and includes clinical CTNM before treatment, pathologic PTNM after surgery, and post-neoadjuvant TTNM after chemoradiation before surgery staging categories. This reflects the known survival impact of multimodality therapy. The pathologic stage includes tumor location for SCC, cervical, upper middle, lower thoracic regions, and tumor grade, how abnormal the cells look, for earlier stages. Clinical and post-neoadjuvant staging just use the TNM classification without location or grade.
How is nodal involvement N status classified?
It's now based purely on the total number of involved nodes. N1 means 1 to 2 positive nodes, N2 is 3-6 positive nodes, and N3 is 7 or more positive nodes. While there's an esophagus-specific regional lymph node map for descriptive purposes, the number of positive nodes is what determines the end stage.
And the T status, that depth of invasion, seems incredibly detailed and critical. Can you walk us through those stages again?
Yes, it's crucial because T stage heavily influences treatment. Tis high-grade dysplasia, severe abnormal cells confined to the very top layer, the epithelium, non-invasive. T1A invades just into the lamina propria or muscularis mucosa, still very superficial. T1B invades into the submucosa, the layer beneath the muscularis mucosa. T2 invades into the main muscle layer, the muscularis propria. T3 invades through the muscle layer into the adventitia, the outer connective tissue layer, but not into adjacent structures. T4A invades usually resectable adjacent structures like the diaphragm, pleura, lung lining, a zygos vein, peritoneum, abdominal lining, or pericardium, heart lining. T4B invades typically unresectable structures like the aorta, vertebral body, spine, or trachea windpipe.
Okay, so what's the typical sequence of these staging tests once cancer is diagnosed by biopsy?
For small, obviously superficial lesions seen on endoscopy, EMR might be the first step after biopsy confirmation, as it provides the most accurate T staging for those early lesions and can even be curative if it's T1A with low-risk features. For larger or potentially deeper lesions, the standard workup usually involves a contrast-enhanced CT scan of the chest and abdomen and integrated PET-CT. These are primarily looking for distant metastatic disease, stage 4. Doing the PET-CT before EUS can be advantageous if it shows clear distant mets. Further invasive staging like EUS might be unnecessary. Or it can identify suspicious lymph nodes far from the tumor that can then be targeted for biopsy during EUS.
So if no distant disease is seen on CTP,
then EUS, endoscopic ultrasound, is typically performed next. This is the best test for assessing the local T stage, depth of invasion, and evaluating regional lymph nodes, end stage. Coupling EUS with fine needle aspiration, FNA biopsy of suspicious-looking nodes significantly increases the accuracy of end staging. EUS is generally superior to CT or PE for determining T and N status, especially for assessing celiac nodes, though slightly less accurate for some other regional nodes. If the tumor is completely obstructing, EUS might not be possible. Bronchoscopy is usually performed for tumors in the proximal or middle third of the esophagus to directly visualize the airway and rule out direct tracheal invasion, which would be T4B.
But EUS isn't perfect for very early tumors.
Correct. EUS accuracy is significantly diminished for distinguishing between T1A, T1B, and T2 tumors. For these more superficial stages, EMR actually provides the most accurate staging information, and throughout this process, thorough and accurate pathologic assessment of all biopsies and resection specimens is absolutely critical.
And all this rigorous staging ultimately dictates the treatment path.
Precisely. Superficial T1A often goes straight to EMR. Locally advanced disease, like T3 or T2 with positive nodes, typically requires a multimodality approach, usually involving chemotherapy and radiation before surgery. Stage IV disease usually means systemic therapy or palliative care. Getting the stage wrong, either understaging or overstaging, can lead to inappropriate treatment, either undertreating aggressive disease or subjecting a patient to overly toxic or morbid therapy unnecessarily.
Let's talk specifically about the approach to early-stage esophageal cancer, where you mentioned that there's been a significant shift recently.
Yes. Over the last 15 years or so, with much better endoscopic technology and a deeper understanding of how these early tumors behave, there's been a definite increase in using endoscopic therapies not just for diagnosis and staging, but as the primary treatment for many superficial cancers. This means traditional surgery, esophagectomy, is likely to play a smaller role for superficial cancers moving forward.
Which makes collaboration crucial.
Absolutely. Given these evolving options, multidisciplinary care involving close collaboration between surgeons, gastroenterologists who perform the endoscopies, and pathologists who interpret the biopsies and resections is essential for achieving the best long-term outcomes.
So for high-grade dysplasia, HGD, and superficial cancers, particularly those arising in bare esophagus, endoscopic therapies are now really front and center.
That's right. While Barrett's itself is a major risk factor for adenocarcinoma, the actual annual risk of an individual patient progressing to cancer is relatively low, maybe around 0.12% per year if there's no dysplasia. The focus has shifted from just monitoring Barrett's to actively treating dysplasia, those precancerous cellular changes, especially high-grade dysplasia, HGD. Historically, esophagectomy was often recommended for HGD because finding invasive cancer within the surgical specimen was common, up to 50% in some older series, and we didn't have good ways to reverse the dysplasia. Surgery offered high cure rates in those cases, but obviously carried significant morbidity.
But there was also a concern about overtreatment, right? Maybe not all HGD progresses.
Exactly. Evidence emerged suggesting that perhaps only a minority of flat HGD, without visible nodules, actually progresses rapidly to invasive cancer. There was also variability in how pathologists interpreted dysplasia. Plus, the high rate of cancer found in surgical specimens might have partly reflected a very diligent search for any microscopic invasion once the whole esophagus was available. Current data suggests the annual cancer risk in non-dysplastic Barrett's is low, maybe 0.39%, rising slightly for low-grade dysplasia, around 0.77%. To improve detection and monitoring, the Seattle biopsy protocol became standard, those 4-quadrant biopsies every 1 centimeter, plus targeted biopsies of any visible irregularity.
And new endoscopic imaging techniques are helping even more with finding these subtle dysplastic areas.
Definitely. High-resolution endoscopy provides much clearer images. Techniques like chrome-1 endoscopy using dyes or simulated chrome-1 endoscopy like narrowband imaging, NBI, enhance visualization. NBI uses special light filters to highlight the mucosal vascular patterns, which become irregular in dysplasia. It's associated with high accuracy in diagnosing dysplasia.
Are there other advanced imaging methods?
Yes, things like autofluorescence endoscopy, optical coherence tomography, like ultrasound with light, and confocal endomicroscopy, providing microscopic views in real time, are also used in some centers to increase sensitivity, reduce random biopsies, and improve diagnostic accuracy. Based on all this, current guidelines from groups like the American College of Gastroenterology now recommend that all patients with low-grade dysplasia undergo endoscopic eradication therapy, though yearly surveillance is an acceptable alternative. And importantly, all patients with high-grade dysplasia should undergo endoscopic therapy if medically able because of the higher progression risk.
So what are these therapeutic approaches? Ablation seems to be a key one for flat dysplasia.
Yes, ablation techniques have largely supplanted esophagectomy for HGD, especially flat HGD. Their main limitation is they only treat superficially, they don't penetrate deeply. Radiofrequency ablation, RFA, is the most common and best studied method. It's generally more effective than older techniques like photodynamic therapy and has lower rates of complications like strictures.
How does RFA work?
It uses a bipolar electrode, often on a balloon or a focal catheter, to deliver radiofrequency energy. This generates controlled heat that destroys the superficial dysplastic tissue layer. The body then heals by replacing the ablated Barrett's mucosa with healthy neosquamous mucosa, basically, new skin-like lining. The standard program usually involves treating the entire Barrett's segment, often with 2 double pulses of energy, followed by touch-up sessions for any residual patches.
And the results are good. How effective is RFA?
Studies have shown impressive effectiveness. The key AIM-2 trial demonstrated 81% eradication of high-grade dysplasia and 90% eradication of low-grade dysplasia, with a very low progression rate to cancer, only 4% in the treated group. A European trial focusing on low-grade dysplasia found only 1.5% of ablated patients progressed versus 8.8% in the surveillance-only group, with over 92% achieving complete dysplasia and eradication. A large registry study confirmed these findings, with only 2% developing cancer after RFA and a very low disease-specific mortality rate, 0.2%. It's made a huge difference.
What about cryotherapy as an alternative ablation method? using cold instead of heat.
Cryotherapy is another ablative technique gaining traction. It uses extreme cold, usually from liquid nitrogen delivered via an endoscopic spray catheter or balloon, a negative is 196 degrees C, to freeze and destroy the abnormal tissue. It's generally well tolerated, causes little pain, has low stricture rates, and doesn't require direct probe contact, which can be useful for irregular surfaces. A decompression tube is needed to manage the expanding nitrogen gas.
Is it as effective as RFA?
Large registry series show high eradication rates, 91% for low-grade dysplasia, 81% for HGD. It's also used in combination with EMR for HG intramucosal cancer, achieving nearly 90% eradication at 5 years in some studies. It's also a valuable salvage option after failed RFA. Reports suggest similar efficacy to RFA, but we lack large head-to-head comparative trials currently.
And crucially, after ablation, surveillance must continue.
Yes, absolutely. Close endoscopic surveillance and long-term acid suppression with PPIs are essential. Many patients require more than one ablation session for complete eradication. Follow-up is typically intense initially, maybe every 3 months for the first year after eradicating HGD or intramucosal cancer, then spaced out. Any residual Barrett's found is focally ablated. There is a small risk of developing buried glands islands of Barrett's hidden underneath the new squamous lining. Malignancy can potentially arise from these, and they're hard to detect, though the incidence seems low and the clinical significance isn't fully clear. But this possibility justifies continued long-term surveillance.
Okay, that covers ablation. Now, what about endoscopic mucosal resection, or EMR? How does that fit in? It seems more involved than just ablation.
It is. Ablation has limitations. Limited depth and no tissue sample for definitive pathology. EMR addresses these. It's used primarily for any nodular or visibly raised areas within Barrett's or any distinct abnormalities suggestive of superficial invasive cancer. EMR allows for the removal of larger specimens to accurately determine the depth of invasion. It actually resects the full thickness of the mucosa and part of the submucosa. This makes it not only a diagnostic tool, but also a good therapeutic option for superficial lesions that have a low risk of spreading to lymph nodes.
How effective is EMR as treatment?
Very effective for the right lesions. A large study following 1,000 patients with mucosal adenocarcinoma, T1A, treated primarily with EMR, showed a remarkable 93.8% long-term eradication rate at nearly 5 years median follow-up.
But EMR doesn't address potential lymph node spread, right? So how do you decide who's suitable?
That's the critical question, requiring careful individualization. EMR itself doesn't treat lymph nodes. The decision hinges on the estimated risk of nodal metastasis based on the EMR specimen's pathology. For T1A lesions invading only lamina propria or muscularis mucosa, the overall risk is very low, generally less than 2%. However, the risk increases slightly with larger size, 2 centimeters, intermediate or high-grade differentiation, or the presence of lymphovascular invasion, cancer cells seen in tiny blood vessels or lymphatics. EMR is generally considered curative for low-risk T1A lesions. For T1B tumors invading the submucosa, the risk of nodal mets increases significantly with the depth of submucosal invasion. EMR can technically remove T1B lesions, but it's generally not considered adequate as the sole treatment for deeper submucosal invasion, SM2 or SM3 layers, where nodal involvement can be around 40%. However, for very superficial submucosal invasion, SM1, just the top third, the nodal risk is relatively low, perhaps less than 10%, especially for low-risk adenocarcinoma. T1B SEC generally has a higher nodal risk than T1B adenocarcinoma.
So EMR helps stage these tricky superficial tumors better than EUS?
Yes. As we mentioned, EUS has low accuracy for assessing T status for superficial tumors. Therefore, performing EMR, especially by an expert endoscopist, provides the most accurate staging information for these early lesions. And again, thorough and accurate pathologic assessment of that EMR specimen is absolutely critical to determine if EMR alone was sufficient or if further treatment like surgery is needed due to high-risk features or deeper invasion.
So the NCCN guidelines now prefer endoscopic therapy for these very early stages.
Yes, the guidelines strongly recommend EMR plus antispallation for TIS, HGD, and T1A tumors as preferred therapy over surgery. EMR is also considered a reasonable alternative to surgery for carefully selected superficial T1B, SM1 adenocarcinomas that have low-risk features, small size, good differentiation, no lymphovascular invasion.
What are the risks of EMR itself?
Complications can include bleeding, usually manageable endoscopically, stricture formation, especially if a large area or the full circumference is resected. About a third might need dilatation later, but long-term dysphagia is less common, pain, and rarely perforation. Combining focused EMR for visible lesions with ablation for the remaining flat Barrett's generally leads to lower complication rates than resecting the entire Barrett segment.
How is EMR actually done?
There are a couple of main techniques. One involves submucosal lifting, injecting fluid under the lesion to raise it up like a cushion, then sucking the lesion into a cap fitted on the endoscope and cutting it off with a snare. Another common method uses suction to raise the lesion, applies a rubber band around its base to create a pseudopolyp, and then snares off the banded tissue. A drawback is that larger lesions often need to be removed piecemeal in multiple fragments, which can make precise pathologic assessment of margins and depth a bit more challenging. A more advanced technique, mainly used in specialized centers, is endoscopic submucosal dissection, ESD. This uses specialized knives to dissect under the lesion more widely, allowing for en-bloc, one-piece resection of larger lesions. Its safety and availability outside these expert centers are still evolving.
And post-EMR surveillance is similar to post-ablation.
Yes, high-dose PPIs are essential for healing. Many patients require multiple EMR sessions to clear all visible lesions. Short interval follow-up endoscopy, for example at 3 months, is crucial. Any residual flat Barrett's is typically ablated. Surveillance continues, often every 3 months for the first year after treating HD intramucosal cancer, then spaced out based on findings. FDG PT scans have no value for managing or surveilling these superficial lesions.
So, given the success of these endoscopic therapies, when does esophagectomy, surgical removal of the esophagus, still play a role for early-stage cancer?
Its role as a primary single-modality treatment for early-stage cancer is definitely diminishing. Most cancers are found either when they're already locally advanced and symptomatic, or they are found asymptomatically during Barrett surveillance, in which case they are usually superficial and amenable to endoscopic treatment. This leaves a relatively narrow subset of patients with early-stage cancer for whom esophagectomy is still considered the primary recommendation. This typically includes T1b tumors invading the submucosa because of their significant risk of lymph node metastasis, except perhaps those very low-risk SM1 adenocarcinomas we discussed, some high-risk T1a lesions, for example larger size, presence of lymphovascular invasion may be poorly differentiated, and perhaps very expensive multifocal or ulcerated superficial disease that might be technically very difficult or impossible to completely eradicate endoscopically.
There seems to be ongoing debate or controversy regarding the optimal treatment for clinical T2 and XER tumors, those invading the muscle layer but seemingly without lymph node involvement on initial staging.
That's a really tricky area, yes. While pathologic T2 and XER cancer, confirmed after surgery, has a reasonable 5-year survival, 40 to 65%, the problem is that clinical staging for T2 and XER based on imaging, US CTPT, is inaccurate in the majority of cases. Many patients staged clinically as T2 and XER are found to have positive lymph nodes upstaging on the final surgical pathology. The landmark CROSS trial, which established the benefit of neoadjuvant chemoradiation, actually included very few CT2 and XER patients. Some retrospective analyses suggest there might be no survival advantage for adding neoadjuvant therapy in this specific group compared to upfront surgery. One approach gaining traction is selective neoadjuvant therapy for CT2 and all XER patients only if their risk of being upstaged is estimated to be high. Example 48% based on factors like tumor length 3 cm, lymphovascular invasion high grade. And again, liberal use of diagnostic EMR is appropriate here, as many tumors clinically staged as T2 might actually be T1b on more accurate EMR pathology, potentially avoiding surgery altogether. Vagal-sparing esophagectomy has been advocated in the past for early cancers, but again, EMR now handles most of the truly low-risk lesions, where preserving the vagus nerves might have been most beneficial.
And when esophagectomy is performed, what are the main surgical techniques?
There have been ongoing debates about the best approach. A key randomized trial compared transhiatal esophagectomy, done through neck and abdominal incisions, avoiding opening the chest, versus an extended transthoracic approach, TTE involving opening the chest, usually the right side, allowing a more extensive lymph node dissection. The trial found lower perioperative morbidity, fewer complications, with GE, but a trend towards improved overall and disease-free survival with TTE, likely due to the more extensive lymphadentomy possible with the open chest approach. Getting an adequate lymph node yield, minimum 23 nodes is often cited, seems important for maximal survival benefit. More recently, minimally invasive esophagectomy, MAME, has gained significant favor. Studies suggest MAM is associated with shorter hospital stays and similar 30-day mortality and 3-year survival compared to open surgery.
Are there different types of MAE?
Yes. A popular approach is a hybrid esophagectomy, like the Ivor-Lewis MIE, which combines a laparoscopic abdominal phase for mobilizing the stomach with an open right thoracotomy for the esophageal resection and anastomosis. This approach has shown almost half as many major complications, primarily driven by fewer pulmonary events compared to fully open procedures, while maintaining similar 3-year survival rates. Fully minimally invasive approaches, laparoscopic abdomen and thoracoscopic chest, are also performed. Robotic-assisted ME is another technique showing excellent oncologic outcomes, although it has a significant learning curve for the surgical team.
But esophagectomy remains a major operation with significant risks.
Absolutely. Even with modern techniques and care, the perioperative outcomes reported by large databases like the Society of Thoracic Surgeons, STS, are substantial. 30-day mortality around 3.4%, major morbidity, serious complications, around 33.1%. Common major issues include needing to return to the operating room, 15.6%, anastomotic leaks where the connection fails, 12.9%, needing reintubation, 12.2%, and pneumonia, 12.2%. To mitigate these risks, enhanced recovery after surgery, ERAS programs, are being widely implemented for esophagectomy. These standardized pathways optimize care before, during, and after surgery and have been shown to lead to less ICU days, shorter lengths of stay, reduced costs, and fewer postoperative complications. Ultimately, patients facing surgery for early-stage cancer have increasingly complex options, requiring thorough discussion and informed decisions, balancing the effectiveness of therapies with their risks and impact on quality of life.
Okay, that brings us to the challenging scenario of locally advanced esophageal cancer. Unfortunately, this is how the majority of patients still present.
Yes, sadly. Once dysphagia becomes the main symptom, it usually means the tumor has grown through the esophageal wall, T3 stage. At this point, the probability of lymph node metastases is very high, around 80%. So most patients present with clinical stage T3, often with N1-N3 disease. Reflecting the importance of treatment response, the 8th edition AJCC staging now includes APTNM, the pathologic stage after neoadjuvant therapy but before surgery. This acknowledges the survival benefit seen with multimodality treatment. As we discussed, nodal staging, N1, N2, N3, is based purely on the number of positive nodes, as this strongly correlates with prognosis. While the anatomic location of involved nodes isn't formally part of the end stage anymore, it still influences clinical decision-making and survival, e.g. nodes near the celiac axis or high in the mediastinum. A clear, rigorous definition of locally advanced esophageal cancer is necessary to guide pre-treatment therapeutic decisions.
And does the expected pattern of nodal spread differ between adenocarcinoma and squamous cell carcinoma?
Generally, yes, reflecting their typical primary locations. For adenocarcinoma, usually in the distal esophagus GEJ, nodal disease spreading from the celiac axis in the abdomen up to the paratracheal region, high in the chest, is typically considered regional. Spread beyond that is usually distant, M1. For SCC, often in the mid or proximal esophagus, even involvement of periesophageal cervical lymph nodes in the neck is considered regional. Tumor differentiation, grade, is also considered in pathologic staging. Ultimately, the overall disease burden dictates the treatment strategy, and these complex therapeutic decisions are best discussed in a multidisciplinary setting involving surgeons, medical oncologists, radiation oncologists, gastroenterologists, and pathologists.
Shifting now to the principles of multimodality therapy for locally advanced esophageal cancer. It sounds like surgery alone is recognized as insufficient for these more advanced stages.
Correct. For many years, surgical resection was the mainstay, but results were often poor for locoregionally advanced disease. Even radical resections, while potentially clearing the local tumor, were inadequate because distant recurrence, metastasis was, and often still is, the main cause of death. While more extensive surgery, like extended lymphadenectomy, leads to better locoregional control, it doesn't address microscopic metastatic disease that has already spread. There are limits to what surgery alone can achieve, plus historical variability in surgical quality impacted outcomes.
So this led to integrating non-surgical therapies like chemotherapy and radiation.
Precisely. As our understanding of cancer biology grew, chemotherapy and radiation therapy were developed and integrated. Giving chemotherapy concomitantly with radiation therapy provides a synergistic effect. They work better together than either alone, increasing tumor killing even at lower doses. This combination targets both the local regional disease and potential systemic micrometastases. Administering this neoadjuvantly, meaning before surgery, allows us to assess the tumor's biological response pathologically in the resected specimen, and we know this response strongly correlates with long-term outcome. Current standard regimens often involve platinum compounds, cisplatin or carboplatin, combined with either 5-fluorouracil or taxanes, like paclitaxel.
What have clinical trials shown about adding chemotherapy to surgery?
Several key trials shaped our understanding. An early trial by Roth showed that patients who had a major or complete response to preoperative chemotherapy lived longer, highlighting that tumor biology matters. The UK's MRC trial compared chemo plus surgery versus surgery alone and found a significant survival benefit for the combined approach. 5-year survival 23% and 17%, benefiting both adenocarcinoma and SCC. The MAGIC trial, primarily in gastric cancer but including an esophageal GEJ subgroup, also showed a survival advantage and better R0 resection rates with neoadjuvant chemotherapy.
What about giving chemo after surgery, adjuvant?
Results for adjuvant chemotherapy have generally not been convincing in large trials for esophageal cancer. However, a Japanese trial, JCOG 9907, specifically in SCC, compared neoadjuvant versus adjuvant chemo. The neoadjuvant group had significantly better progression-free survival, 3 versus 2 years, and 5-year overall survival, 60% made to 38%, leading to the trial being stopped early due to the clear benefit of giving chemo before surgery.
And what about using chemoradiation definitively without any surgery plan?
Yeah, that's another important strategy. The landmark RTOG 8501 trial established that both SCC and adenocarcinoma could potentially be cured with bimodality therapy, chemo plus radiation alone. A later trial, intergroup 0123 RTOG 9405, tested a higher radiation dose, 64.8 Gy versus 50.4 RGy, with chemo, but found no survival improvement and significantly worse toxicity and treatment-related deaths. This established 50.4 Gy as the standard radiation dose for both potentially definitive chemoradiation and as the neoadjuvant dose before surgery.
Okay, so that brings us to combining all three, chemoradiation and surgery, or trimodality therapy. This sounds like the most comprehensive approach for locally advanced disease.
Since each modality surgery, chemo radiation has limitations on its own, combining them in trimodality therapy maximizes the chances of effectively treating both locoregional disease and potential undetectable metastases. While some early trials didn't show a clear advantage over surgery alone, often due to design flaws, mixed patient groups, or inconsistent surgery, the CROSS trial, published in 2012, was truly practice-changing.
Remind us of the key findings of CROSS that were so impactful.
CROSS randomized 368 patients with resectable esophageal or GEJ cancer, mostly T23, N01, 75% adenocarcinoma, 22% SCC, to either surgery alone or neoadjuvant chemoradiation, 5 weeks of carboplatin paclitaxel plus 41.4 G radiation, followed by surgery 4 to 6 weeks later. The results were striking. The R0 reception rate, complete tumor removal, was significantly higher in the trimodality group, 92% and 69%. Pathologic complete response, PCR, meaning no viable tumor left in the specimen, was achieved in 29% of adenocarcinoma patients and an impressive 49% of SCC patients receiving chemoradiation. Nodal positivity was much lower after chemoradiation, 31%, says 75% in the surgery alone group. Most importantly, trimodality therapy resulted in significantly longer median overall survival, 49.4 months versus 24 months for surgery alone. The estimated 5-year survival was 47% versus 34%. While the initial analysis questioned the benefit specifically for adenocarcinoma, longer follow-up confirmed survival benefit in both SCC and adenocarcinoma.
So after CROSS, trimodality therapy became the standard of care in many places for potentially resectable, locally advanced esophageal cancer. But are there still unanswered questions about the role of surgery within this and about salvage surgery?
Absolutely. Despite CROSS, key questions remain. We still can't reliably predict before treatment which patients won't benefit from neoadjuvant therapy, or conversely, which patients might be completely cured by the chemoradiation alone and could potentially avoid the morbidity of surgery. So far, only the histopathologic tumor response after neoadjuvant therapy has emerged as a predictor of survival. Finding minimal or no residual cancer in the surgical specimen is a very strong positive prognostic factor. This means that surgical resection to assess that response continues to be critically important in the trimodality pathway.
What about comparing preoperative chemo alone versus preoperative chemoradiation?
Another trial randomized patients, mostly GEJ adenocarcinoma, to either induction chemo or chemoradiation before surgery. The trimodality chemoradiation group had significantly higher rates of pathologic complete response in tumor-free lymph nodes. While it showed a trend towards better 3-year survival, 47.4%, Beckus 27.7%, the difference didn't reach statistical significance, likely due to poor accrual stopping the trial early. Meta-analyses combining multiple trials do provide strong evidence for the survival benefit of multimodality therapy, either chemo or chemoradiation, versus surgery alone, and suggest a mortality reduction with trimodality versus induction chemo alone, though sometimes just shy of statistical significance.
So surgery still seems valuable after chemoradiation.
Yes, studies continue to show that surgical resection itself, along with factors like tumor differentiation, remain independent predictors of survival even after neoadjuvant therapy. However, this relies on achieving impeccable perioperative outcomes, low complication rates, and mortality for the benefit to be realized. This leads to the concept of selective salvage esophagectomy. This strategy involves giving definitive intent chemoradiation first, and then using esophageal resection selectively only for patients who have disease persistence or recurrence identified during follow-up.
How well does salvage surgery work?
The RTOG 0246 trial specifically tested this. About half the patients ended up needing salvage esophagectomy. Overall survival was best for those who had a complete clinical response to chemoradiation, 53%, intermediate for those salvaged by surgery after an incomplete response, 41%, and lowest for those with an incomplete response who didn't get surgery, 33%. The trial didn't meet its primary endpoint, but subsequent studies suggest that salvage esophagectomy, while carrying higher postoperative morbidity and mortality due to operating in a previously irradiated field, may confer survival that approaches planned trimodality therapy for carefully selected patients, particularly those with recurrence rather than just persistent disease. Its exact role remains a potentially feasible treatment strategy under investigation.
Given these different pathways, what does surveillance look like for patients, especially after definitive chemoradiation without immediate surgery?
Surveillance after definitive chemoradiation, bimodality therapy, is primarily aimed at detecting locoregional failure early enough to potentially offer salvage therapy like surgery. Currently, there are no high-level evidence-based algorithms. NCCN guidelines and expert opinion generally suggest regular clinical examination, endoscopy, and imaging, CT chest abdomen plus MASH and PET, every 3 to 6 months for the first few years.
But is it always helpful?
That's the debate. This intensive surveillance is costly, anxiety-provoking for patients, and unfortunately may not change the ultimate outcome if the cancer recurs systemically. Distant metastasis. However, since more than 98% of local recurrences occur in the first 36 months, vigilant surveillance during this period is considered crucial by many to maximize the chance of catching treatable recurrences early.
And finally, for patients who aren't candidates for curative intent therapy, those with poor health or metastatic disease, what are the palliative options for esophageal cancer?
For patients with poor performance status or confirmed distant metastatic disease, stage 4, who aren't candidates for aggressive multimodality therapy, the goals shift entirely to palliation, relieving existing symptoms and potentially avoiding future complications like complete obstruction or bleeding.
What symptoms are typically targeted?
Dysphagia, difficulty swallowing is usually the main one, but also odynophagia, painful swallowing, chest pain, fatigue, and weight loss nutritional decline. Treatment is highly individualized based on the patient's condition, symptoms, disease extent, and their own wishes. Options include best supportive care, focusing on comfort, palliative chemotherapy, which can sometimes shrink tumors and relieve symptoms, palliative radiation, often very effective for relieving dysphagia or pain from localized deposits, esophageal stent placement to physically open up a blockage and allow swallowing, and nutritional support, often via enteral feeding tubes, like a gastrostomy or a jejunostomy tube.
Does surgery have any role in palliation anymore?
Surgical procedures purely for palliation have become exceedingly rare nowadays. This is thanks to significant advancements in less invasive image-guided percutaneous procedures, like feeding tube placement, and therapeutic endoscopy, like stent placement, that can achieve similar goals with much lower morbidity. One exciting development in palliative care, and potentially moving earlier in treatment, is immunotherapy. Checkpoint inhibitors, which help the patient's own immune system fight the cancer, have shown promising results in advanced esophageal carcinoma, offering improved survival and symptom control for some patients. This is an area of intense ongoing investigation and may represent a novel treatment approach for many.
So we've really journeyed far today, from the amazing, often just overlooked precision of the healthy esophagus and its incredibly complex anatomy, Through the whole myriad of motility disorders and diverticula to profound challenges in the constantly evolving multidisciplinary treatments for GRD and the truly formidable beast that is esophageal cancer. It's a remarkably intricate and, in some ways, resilient organ.
It really is. And it's clear that, one could literally spend a lifetime delving into each of these areas. But hopefully, through this deep dive, you, the listener, have gained that mastering understanding, those core insights into what elite professionals in this field grapple with every single day.
And as we reflect back on our opening statement that nothing functions as well as the original healthy organ, it really does raise an important question for us all to ponder, doesn't it? Given all this incredible progress we've discussed, the intricate surgeries, the targeted therapies, the amazing endoscopic innovations for managing diseased parts, what deeper biological secrets still elude us? What is it that prevents true renewal, perfect self-repair of complex organs like the esophagus?
Yeah, what innovations in, say, regenerative medicine or truly personalized therapies might future generations unlock? Will they be able to achieve that ultimate goal, moving beyond even the most advanced current fixes toward genuine biological restoration? It's a really fascinating frontier to think about.
It truly is. And perhaps it just reminds us to appreciate the delicate balance of our own biology and also the constant, relentless pursuit of knowledge and innovation in medicine that we've explored today. We hope this deep dive leaves you not just informed, but maybe also inspired by the sheer complexity of the human body and the dedication of those working to understand and heal it.